Anemia.
Yeah.
Please. Jha, yes. Ratan Jha, yes. Yes.
Can you just see the slides? Already copied. Just see the slides.
One moment, sir. First of all, I copy that over there.
Videos are just to open it.
One moment, sir.
It's already copied, sir. Yeah.
One moment, sir. One moment. Yes, we can start.
Between 5 and minutes.
Okay. How? Yes, okay. Properly.
Just see that presentation.
Check. Can we start?
Yes, yes, okay.
Once we live.
Yes, we are live.
Good evening. It takes a privilege to welcome each one of you for this symposium, and Microlabs Limited is happy to be as academic partner for today's program. Before proceeding to the program, I would welcome Dr. P.P. Verma sir to come on the stage, Dr. Vijay K, Dr. Ashwin Goyal, Dr. L.K. Tripathi, and Dr. C. Arvind to lighten the lamp.
WhatsApp
Thank you.
Thank you all. Now, I take this great privilege to welcome Mr. N.K. Raja, Vice President of Microlabs Limited and today's academic support partner. I welcome on the stage to give a welcome note for this session.
Good evening, one and all. It's a great privilege for Microlabs to support this academic initiative of ACME as part of our knowledge dissemination program. Dear doctors, you all must be aware that Microlabs is close to about a 49-year-old company and will be stepping into our 50th year by next year. So on the occasion of this prestigious moment, we feel extremely happy to have all the senior-most key opinion leaders of the country today at this place to have this a wonderful knowledge dissemination program. You must be aware that Microlabs has been onto the limelight of late with the brand Rolo 650, which has been really a big brand today in the minds of from the doctors to the common public during this recent COVID. And all this would not have happened without the wholehearted support given by each and every one of the doctors. So we extremely take this opportunity to express our gratitude for trusting this brand, and therefore the benefits are being passed on to the patients. Thank you very much, doctor. Now coming to this particular event, Microlabs always have been believer of a knowledge dissemination program. In fact, this initiative called REGAIN, the recent evidence-based advances and growth in nephrology, have been the brainchild of our course directors, which was started in the year 2019 during the COVID first wave, when we were all in the lockdown, that PGs were clueless about how to get themselves connected with the seniors, where they were not able to get their coachings and trainings on time. We came as a rescuer to each and every student, trying to get themselves connected with all the senior most KOLs in the country. Today, I'm extremely happy to share this, that we have completed 50 programs over the last 3 years, just only over the online portal. So we are extremely thankful to each and every one of our course directors. In fact, the module have been done in a several fashion, like season 1, season 2, then we had a landmark trials, then we had master clinic, which is currently on, and today we are trying to share the best of EDT. So I think this a journey which has been started by Microlabs will continue to go on with the support of each and every one of us. And certainly, I take all the happiness to thank our board directors, Lieutenant Colonel Dr. P.P. Verma, as well as Dr. Vijay here, who have been extremely encouraging us to do this program. Thank you very much, both of our board directors, for this program. So I take this opportunity to welcome each and every one of the delegates for today's occasion. And today, without wasting much of our time, I request Dr. P.P. Verma to come over here and introduce the speakers of the day and take the session from here on the best of the evening. Thank you very much for your patience, questions, all of you. Over to you, Dr. P.P.
Thank you, Mr. Raja, and I welcome each and every one of you for this REGAIN seminar or CMA and symposium. Before I proceed further, I will request the most respected teacher, the academician, one of the most respected nephrologists of country, Professor Vijay K, my co-director also, to please come on stage. We both got together and worked a bit for formulation of this program. We have got a galaxy of people here, galaxy of nephrologists of India, Professor Ashwin Gupta, Professor Ashwin Goyal, Professor Sanjeev Gulati, Professor Arvind, Professor Tripathi, Professor Dilip Balla, so many of them. I think it's an honor for Microlab also, and for this symposium to have such galaxy of nephrologists, learned and respected nephrologists who have been kind enough to come and grace this seminar. We formulated that we will have 3 small sessions for this. One will be the best of EDTA. So we know that EDTA was covered over 40 hours. We want to cover, give a glimpse of that over 1 hour period. Second session will be on anemia management, which is preceded initially by Professor Sanjeev Gulati, who will talk on newer perspective in anemia management. After that, there will be a panel discussion. And third session will be on challenging or interesting cases which we come across. We have tried to keep the symposium more clinical rather than basic sciences, so that it should impact the practice of every nephrologist. Before we come to the first session, I request Professor Vijay to say a few words, and after that we go.
Thank you, and again, on behalf of ACME, I would like to welcome you to this session. And it's been, as Mr. Raja said, that the Recurrent Symposium has been going on for the last 3 years. It's been a pleasure and a privilege to be associated with this teaching activity over the last 3 years. And I must say that the most well-attended sessions that we have had has been the master clinics in the Recurrent Symposium. And we usually get about 130, 140 people who are actively logged in to the program. And that's been a great kind of success. And that's predominantly that me and Dr. Pooja and Dr. Verma have been picking up good people to moderate these sessions and to provide the experience. A lot of evidence is available these days, but evidence alone, as most of you would know, is not essential, is not the only thing that can guide you in your practice. Evidence is important, no doubt about that. But you require clinical experience of difficult patients who require immediate judgments, and you do not have evidence by which you can go ahead. And for that, these kind of sessions are extremely, and I must say that very glad to see that a lot of nephrologists, not only trained, but a lot of nephrologists, practicing nephrologists do log on. And that's something which encourages us, and we continue to be associated with this. Without wasting time, I think let's start straight away, as General Rama has already given you a glimpse of what is going to happen. And I think I'll go back to General Rama and say that he gives you an introductory part of the glimpses of EDTA, and then we'll have 3 sessions. 3 people immediately, but I think 2 people probably are not immediately here, but we might have their lectures at the end of the sessions. So let's see when they come. But each speaker will have, I will have to, because time is important, otherwise you're going to be, most of you are with your spouses, you're going to get labored if you keep on extending this session. So be careful that the speaker should speak for 10 minutes, we should leave 5 minutes for the discussion. So the discussion is extremely important, because that's where the things will get sorted out. So leave time for the speakers. General, all yours.
Thank you, Professor K. As I said, this conference, 59 EDTA, was held in Paris from 19th to 22nd May. A lot of discussion was carried on here. We are giving you some of the practical discussions which happened. On day one, we had a talk on acute kidney injury, the recent and ongoing trials. This was by Godfrey from France. He initially gave the trials which are already over. So that one was the effect of hydroxy and starch. It was, some people thought that possibly starch or chloride is better than giving crystalloid in patients with major abdominal surgery or major surgery. So they tried this, but eventually in one group of patients, they gave the starch, other group was given saline. It was a negative trial and there was no difference between the two. And the result, rather, in the group which took starch, there were more cases of AKI. Hence, it was concluded that saline is as good as starch. There is no benefit of giving starch in patients with major surgery. Then it was a confirmed trial which was just published in NEJM last year. This was in patients of hepatorenal syndrome. And it was planned whether giving, besides albumin, if we give terlipressin, is it beneficial or not? So here, they took two groups of approximately 2:1 ratio, 200 people on terlipressin for a period of 14 days. After the time in hepatorenal syndrome, creatinine came down to below 1.5. And this was continued, albumin was continued as before in both the arms. And as you see, the clinical success was in 32 out of 32% in terlipressin group versus 17% in placebo, which was statistically significant. So it only confirmed that terlipressin is beneficial in patients with hepatorenal syndrome type 1. Then it came on the timing of start of dialysis. And as we all know, initially it was start AKI trial, a multicentric open label trial in 165 hospitals, 15 countries, conducted till 2019 in critically ill patients. And what they found that almost 1,500 patients were on standard therapy and 1,500 was given accelerated KRT, that is dialysis, within 12 hours of reaching the hospital. As you see, the findings are, there is no difference in mortality. Rather, more patients receive dialysis in the accelerated group and more complications were there in the accelerated group. So the answer was possibly early dialysis is not beneficial. The second trial came ideal ICU trial. Again, multicentric randomized controlled trial from 29 ICUs in France. Almost 500 patients, 215 each group. Again, they found that 90-day mortality was similar and need for renal replacement therapy because you started early in early therapy was much more than in the delayed group. Again, saying that possibly there is no benefit of giving early dialysis in patients coming to ICU. And lastly, the nail on the head was by AKI trial, which again multicentric trial in France in 620 critically ill patients. Again, you find early RRT in 300, delayed RRT in 300 patients. You find mortality at 60 days is similar, and patient requiring dialysis is more if you start early. So the conclusion is there is no benefit of giving early dialysis therapy in patients of AKI. Next, the trial which is going is vitamin B3 in AKI. This was after they saw that in the COVID patients, if they were given nicotinamide B3, the recovery was faster. So this trial is ongoing. It has included 310 patients. One group is being given nicotinamide 500 milligrams twice a day. That is 1 gram a day for 3 days. And the control group is being given placebo. Primary endpoint is protection, that is in-hospital mortality, receive the RRT or persistent renal dysfunction. Trial is ongoing and the results are awaited. Lastly, the START or not START trial. The trial will investigate that once a person develops AKI, we stop ACE inhibitor. Should ACE inhibitor be stopped or not? Professor Arvind is going to talk on this subject. But this trial, which has included 500 patients in ICU, and with the moment AKI develops, one group is continued on ARBs or ACE, other group is stopped. So they want to study whether continuing ACE and ARBs is going to be beneficial or harmful. Trial is ongoing and the results are awaited. Lastly, as I mentioned, this was a trial study, which was a small study in US, which was done in almost 200 patients of COVID-related AKI, where vitamin B3 was given in a small study, single center, and you find the need for dialysis was less in patients who were given B3, 55.9 versus 42%. The total mortality was less, and the rise in creatinine was less if nicotinamide was given. The nicotinamide basically is NAD, is false NAD. It is taken up by the proximal tubules, where there is setting of hypoxia in AKI. If NAD is already available, possibly hypoxia is less and the damage is less. Next study, interesting, was cognitive function in dialysis and transplantation. Mind you, these are the two studies at a different period of time from US. Mean age 71 years, the other group, recent study by Drew et al. 2020, mean age 64 years. Dialysis vintage is between 2.5 to 3 years. What you find, only 13% of dialysis patients, in another 20% have got normal cognitive functions. All others have got deranged cognitive function. Deranged cognitive function means more depression, inability to look after oneself, more infections, more mortality. And if you look, there are different ways to study what is happening, whether you do a transcranial Doppler. If you do a transcranial Doppler in dialysis population, there is 10% less blood flow in dialysis population versus other population. You can do PET, which is far more superior, time consuming, because trans Doppler can do the major vessels, it can't study the smaller vessels, whereas PET can do that. Third is an infrared study you can do, which is again beneficial. Keep in mind, the first and second, the incidence of stroke is double in patients on dialysis because of ischemia. What you find, that once there is ischemia, you use a hot dialysate, you use rapid ultrafiltration, there is less blood flow to the brain, and besides all the other risk factors, there is more of interconnections are gone, cognitive functions is gone. We will come to this slide. Interesting. If you see first slide, 123 patient transition to dialysis, 37 patient. You look at the red line on the right side, the cognitive function is declining. The other slide, again very interesting. Here, 25 patients of PD, and the cognitive function is not declining. But again, 41 patients of HD, cognitive function is declining. The etiology, as we all know, repetitive HD induced fall in cerebral perfusion, excessive ultrafiltration, too high dialysate temperature, besides the common comorbidities which are common to these patients. The inference is cognitive impairment is frequent in dialysis patients. Over 75% of them have it. Dialysis procedure reduces cerebral blood flow and contributes to cerebral damage. Possibly cool dialysate fluid, peritoneal dialysis, and early transplantation can reduce or reverse the cognitive decline in these patients. Last one or two, one was page studies. One was an open label crossover study, because now gradually sodium zirconium crystalloxicate is going to be available. So whether it affects the tacrolimus blood level, that was the study done. If you look at the upper study, the blue line is only tacrolimus, the red line is the tacrolimus plus this potassium binder. You find if the patient is given potassium binder, absorption of tacrolimus is reduced. So therefore, when you are trying to use that, the recommendation will be that the gap should be of 2 hours. You take tacrolimus, if you have to take this potassium binder, take 2 hours after. Lastly, it was again on tacrolimus. two formulations, we are trying to shift from 2-dose pan-graft to possibly a single dose. So this was comparing the two combinations, that is Advagraft and Anravus. So what they wanted to study was that if they study the fatty acid binding protein of intestine, because tacrolimus has to enter after binding proteins. So they studied FAB1 in both the groups. In one group, they were given Advagraft, the other group was given Anravus. So they found in Anravus, absorption was poor. This is Advagraft. So whenever we are trying to shift from double dose to single dose, one has to keep in mind that one should weigh whether the effectivity will be similar or not. Lastly, I think the first speaker will talk on the issue. There was a lot of talk on half his day was gone on COVID and what is happening with the complications of COVID, and vaccination. Initially was how the COVID people are behaving, studies, how the COVID AKI is behaving. They found out a large study of 10,000 people with AKI in COVID from US. They found that normal people, if the mortality is 10.2 per 1,000 patient days, if there was a COVID associated AKI, it was 33 times higher. And if the patients required dialysis, it became 38.4 per 1,000 patient days. It was even higher. So therefore, COVID-related AKI has got a bad outcome. That was one. Then they talked about vaccination, that what will happen? What is the response to vaccination? So one of the single center study from UK, they pointed out that after giving 2 doses, they gave the third booster to transplant recipient. And they found that the initial response was 46%, but after booster, the response was almost 82%. So that was another study. That other study came, what is the psychological effect of giving vaccination to elderly population? Possibly, they feel happy after receiving the drugs and the booster, that possibly the disease will be mild. Psychologically, they start feeling much better. I think after this, what vaccine can do to cause glomerular disease or the renal damage, I think the speaker for that will be Professor Ashwin Gupta. He is the first speaker on, I'm sure I have not taken more than 10 minutes. Yeah. So I think he will be talking on what COVID vaccine can, how it can damage the kidney and what are the manifestations internationally and his own experience. You know Professor Ashwin Gupta, a very learned, respected and excellent speaker. He speaks few words but makes a substance out of that. May I request Professor Ashwin Gupta to please start.
Thank you, Denervation, for your kind words. Good evening, everyone. It's really a proud privilege for me to share my experience at Gangaram Hospital about glomerular COVID vaccine. Thank you, Dr. K. Sir. During this COVID phase, we have learned that COVID can cause mild respiratory symptoms to severe ARDS, mild asymptomatic urinary abnormalities to severe renal failure, AKI, and glomerular diseases ranging from minimal chain disease to vasculitis. And after the emergency clearance of this vaccine by the WHO in January 21, many case reports have come of glomerular disease following COVID vaccination. As of June 11, 1.95 billion shots have been given in India, and out of that, 1.01 billion were first doses, and about 0.9 billion received the second dose. And about the global progress, 11.1 billion doses have been given worldwide, 68% of world population has received one dose, 62% two doses, and 1/4 of the world eligible population has received an additional dose. 8 vaccines have been cleared by WHO, and you can see that Astra, Corona, Pfizer, Sinopharm, they have been responsible for about 10 billion doses, and our Bharat Biotech has also provided a good share. And I share our experience of about 5 cases which we saw between July 21 to April 22. First case, a 37-year-old female presenting with 5 days history of abdominal pain, nausea, and migrating joint pains. 2 days before admission, she developed chest pain, hemoptysis, and respiratory distress. Admitted to emergency room in severe respiratory distress, tachycardia. She was anemic, and she had to be put on ventilator. And her urine routine showed RBCs, RBC class protein, and serum creatinine 2 days before coming to this hospital was normal, and within 2 days it reached 7.8 milligram. And based on the clinical diagnosis of rapidly progressive renal failure, we started her on antibiotics and flex because of diffuse pulmonary hemorrhage, and she had received Covaxin 15 days prior to start of her illness. And after stabilization on 5th day, we did a biopsy which revealed rapidly progressive crescentic glomerulonephritis. You can see the crescents, and there are no immune deposits. So diagnosis of post-immune ANCA-associated vasculitis was made, and under cover of antibiotics, he was given cyclophosphamide, and she started improving, and she was discharged 2 weeks later with normal renal function, and after a follow-up of 6 months, she's having normal renal function. And the second case, a 38-year-old female who had nephrotic syndrome during her childhood and was in remission since the age of 13 years, presented with progressive edema and frothy urine of 3 weeks duration, and she had received Covishield to a second dose 3 weeks before her onset of symptoms. Her proteinuria was 24 grams, 10.9 grams. Her ANA, anti-PLA2R were negative, complement was negative. We did a kidney biopsy which showed minimal change in these, but there were few focal interstitial infiltrates, and immunofluorescence showed few IgM mesangial deposits. So diagnosis of either minimal change or unsampled FSGS was made. She was started on steroids, and she is in remission. 3 cases, just I am telling you, 21-year-old male was diagnosed with nephrotic syndrome 1 year back, and after a dose of Covishield, he had a relapse of nephrotic state. 1 patient of anti-GBM disease and 1 patient of de novo minimal change disease we saw. So this is about the 5 cases which we have seen. And now coming to vaccination and glomerulopathy, we know from the previous knowledge of vaccines that influenza, pneumonia, rabies, meningococcal, and hepatitis B vaccines are associated with to initiate glomerular disease or initiate a relapse of glomerular disease. And we have seen in children after measles or mumps, they have relapse of nephrotic syndrome. So same way, post-COVID vaccination, de novo and glomerulopathy and relapse of glomerular disease has been reported. Pathophysiology is not known, and it is only the temporal correlation between the vaccination and glomerular disease. So what are the possible mechanisms? As we know that in minimal change disease, there is dysregulation of T cell system. So there is over population of CD positive suppressor, CD positive T8 suppressor T cells. And they, after a vaccine, there is surge in the, there is cytokine storm, and there is Th2 type responses there, and there is formation of cytokines which lead on to negative immunity. While Th1 type responses are a regulated response, and it provides a protective immunity. So it has been seen that here it is Th2 type response. And then vaccine can increase immunogenicity due to surge in cell-mediated and antibody-mediated immune response. And it has been seen that antibodies to SARS-CoV spike protein may cross-react with other cell human antigens, that is antigen mimicry or epitope migration. It promotes autoimmunity and ANCA-associated anti-GBM disease or IgA vasculitis are example of such kind of immune response. So I'm just sharing some world literature, Journal of Neuropharmacology. We have 36 PubMed research with 49 cases, and you can see that 17 cases had minimal change disease. Out of them, 9 were relapse, and the de novo disease was seen in 8 cases. IgA nephropathy was second common diagnosis after vaccination, and you can see majority of them were relapse or flare. And then ANCA-associated glomerulonephritis, new onset 5 cases, anti-GBM disease 1 case, and 1 case each of primary membranous nephropathy, granulomatous, and IgA nephropathy. So this is from American Journal of Nephrology, and all patients were hospitalized between April to November 21 who had undergone a kidney biopsy for new onset urinary abnormalities or renal impairment within 3 months of vaccination. They found that MCD was there in 5 cases, membranous 3 cases, RPGN 2 cases. And 47% of them had some degree of AKI and 2 required dialysis. Another study by Casa, I just share Indian experience. From Nizam, 7 cases have been reported between 7 to 14 days of vaccination. And there are case reports from 4 case reports from India. This is what I could gather. And now whether this is cause or effect, there is a study which has come up with, it's a clinical research and null hypothesis. Do mRNA-based vaccination increase the incidence of glomerulonephritis, and does the observed temporal association between 2 phenomena is purely coincidental? And it has been seen that it is only coincidental. So, is it just coincidence or cause? Think over it. Thank you so much.
Thank you. I should report that review of literature on glomerular disease post-vaccination. And as you said that at the moment the cause and effect relationships between the COVID vaccination and the onset of glomerular disease remains a matter of coincidence, probably, maybe not, because billion doses have been given and probably small percentage of people would develop glomerular diseases otherwise also. So the relationship probably is coincidental and may not necessarily, unless the Cox postulates, which are essential to establish cause and effect relationships between diseases and the positive agent, are proved, it may remain till then a coincidence. Questions? Any questions?
In EDTA, they reported almost 295 cases because Europe has got a registry for any patient after vaccination. The definition they gave was within 1 month of vaccination. If a person is developing, 295 people develop nephrotic syndrome, and the figure is listed like that. And as mentioned, we are not sure, but cause and effect relationship needs to be.
This, as Ashwini said, this has been reported previously with any kind of vaccination, also any kind of bacterial infections. We know, all of you know that minimal change disease gets relapsed with a sore throat or something like that. Many of the glomerular diseases get initiated with some kind of activation, and the pathogenesis of many of these are related to some of these immune activation by a third phenomenon, a bacterial or a viral or any other. Any question? Anyone with an experience or something? Yes, Ashwini.
I had one patient who at the age of 5 years had a nephrotic syndrome which had responded to steroids. Now he was 25, he took the vaccine and a few days later came the frank nephrotic syndrome which responded to the treatment. Now the fellow kept asking me whether it was related to the vaccine. I tried to say there is no real human relationship, but I really didn't know the answer.
Yes, Sanjeev.
If we had a patient, transplant patient, who received the first dose of vaccine, he developed acute rejection. The case report will come in IDP from publication. And again, he responded well. We don't know whether it was due to vaccine or not, but the levels were good prior to that, but he developed acute rejection.
So yeah, we had one patient of 27-year-old healthy male who first developed membranous practice about a month after the vaccination. A biopsy proven PLA2R, and one patient of ANCA-positive vasculitis who was in sustained remission for 1 year. She took the vaccine, she developed a relapse. A few children who relapsed, I am not sure whether they relapsed recently or after the vaccine.
That's the same kind of an experience each one of us. But I must say that, actually, I have had patients who have minimal change at 5 years, no vaccination, without vaccination. They have had a relapse or a new onset minimal change disease 30 years later. Now, I still don't know the relationship between the first minimal change disease, which wasn't biopsy, and I would guess that he responded to steroids, it was minimal change disease. And 30 years later, even without the vaccination, there are some patients who keep on getting. So the relationship between vaccination and this remains still, it's going to be extremely difficult to scientifically prove that there is a relationship. But yes, temporal relationships always bring in whatever you do on that day or night and you get an acute rejection, you feel that probably that's the cause. Yes, Dilip. Anyone else?
Yeah.
So, one experience I've had with one patient, he was exposed to rituximab method and we gave him according to that. He had gone into partial remission, 2 grams, he had COVID. He didn't have COVID, he had COVID. Now his proteinuria from 2 grams went up to almost 6 to 7 grams, stayed at that. So I was not sure whether COVID associated photocytopathy or what. I think biopsy was there, just to make sure what was there, whether there was new onset photocytopathy. The re-biopsy did not show us any photocytopathy. I'm waiting for the hint. So I am perplexed as to it is just the membranous, the COVID, in between he got vaccinated. So I gave him another shot of rituximab because the CD19 also. So we are still in a quandary and dilemma what to do with people.
Yeah, the question is going to be, even before COVID, there were patients of membranous nephropathy who would go into a partial response and some infection would increase their proteinuria. That is not something that would surprise. That COVID also is one of those infections that it would increase proteinuria in some. So infections do increase the degree and severity of proteinuria in many patients with nephrotic syndrome of glomerular diseases, and therefore I would guess that this is also one of those topics. Some kind of an immunity which is possible. I think we should stop here. Thank you, Vaishnavi, for that, and thanks for the experience itself. And we could go next to Dr. Dilip Balla. He's going to talk about the fidelity trials. And as you know that the aldosterone and the non-corticosteroid aldosterone antagonists have been found to be useful. Aldosterone antagonists have been found to be useful for decreasing proteinuria as well. As it's not as well appreciated till recently, till the fidelity trials happened, and it showed that the non-corticosteroid aldosterone inhibition is protective not only for decreasing proteinuria but also for kidney protection, kidney function deterioration, which is known in patients with diabetic nephropathy.
I think so. You have got ACE and ARBs inhibitor. Second is SGLT2. The question is now, fibrinogen is coming. Is it doing a benefit beyond these two?
Good evening, everybody. And at the outset, I would like to thank the micro group for the excellent arrangements and giving us a lovely overview of the side of the country. To be honest, I had never been over here. So going on with the crisis, the cardiovascular and the kidney outcome of fibrinogen in patients with type 2 diabetes and chronic kidney disease. A few words about fibrinogen. It's a novel, selective, non-steroidal mineralocorticoid receptor antagonist, as opposed to your spondylometaphyseal methadone, blocks MR-mediated sodium reabsorption and has importantly anti-inflammatory and anti-fibrotic effects. So this is a very interesting slide. I think we should all understand this because we're going to hear a lot about this molecule for the next 2 years. So basically, fibrinogen acts on the MR receptor. The hemodynamic effects are basically on the hemostatic, on the epithelial of the collecting ducts that we all know. Basically, it stops the sodium reabsorption as well as leads to and reduces the potassium secretion. But more importantly, the anti-inflammatory, anti-fibrotic events, basically on the podocytes, sandal cells, macrophages. So basically, it is called back to this mechanism. Now, it is hypothesized to slow the CKD progression by directly targeting inflammation and fibrosis. Let's look at the inflammation and fibrosis over there, as opposed to SGLT2s, GLP-1s, and metformin, basically acting to hemodynamic and metabolic pathways. So, it's got a slightly novel mechanism of action. Important differences between spironolactone and epinephrine are that it's a smaller molecule, shorter half-life, has less of sexual side effects, and less effect on potassium. So, that's why there's a lot of interest in this molecule. So this fidelity pool analysis, it is a combination of the Fidelio EKG study, which is dependent on reducing kidney failure, disease progression in patients with diabetes, kidney disease, and the Figaro EKG study. So the Figaro study was looking at cardiovascular mortality, and Fidelio was looking at the renal endpoints. So these two studies are complementary, and the main purpose is the main people who organized this study was George Bertels and his group. The Fidelio study was published in ANCA in 2020, and the Figaro was subsequently 2021. Both these trials are the largest cardiac outcome trial in diabetes to date. The pooled analysis of approximately 13,000 patients. It's a huge pool. Fidelio looked at basically the renal endpoints in patients with moderately severe disease with CKD stage 3 and 4 with mild to moderate to heavy proteinuria. Figaro looked at basically patients with CKD but stage 1 and stage 2 with mild proteinuria. So this graph looks very well because at the extreme left is the Fidelio CKD, the DKD trial. The mean GFR in this was 44 ml, and at the second last one, the mean proteinuria was 862 milligrams per gram. The Figaro is opposed to a mean GFR of 68 ml, and the proteinuria was 708 ml. So Fidelio DKD 3 and 4 is around 800 milligrams. Figaro cardiovascular outcomes, GFR of around 68 ml, CKD2 with protein around 300. So this was a full analysis of these two trials. And this is just graphically to present, to show you what it is like. The extreme end tells us how it fits into this graph. The fidelity was looking at both the cardiovascular as well as the renal outcome, and a combination of both the Fidelio as well as the Figaro trials. So the study details, Fidelio was again published in 2020. Figaro in 2021. Sample size was 5,000 patients approximately in Fidelio, the green outcome trial, and Figaro was slightly larger with around 7,000 patients. The inclusion criteria was the same, exclusion criteria was the same. For the period of Fidelio was 2.6 years, and for Figaro it was 3.4 years. And the primary outcome in the Fidelio was time to kidney failure with a sustained decrease of more than 40% decrease in GFR or renal death. The Figaro looked at the 4 key ways endpoints. So the study design was such, there was an informed consent, there was a 4 to 6 weeks of running period. What was important that all the patients of both these trials had to be optimized according to the ACE and the ERPs. So they were an optimized treatment with ACE ERPs. On top of that, then Pindolone was added. If the GFR was less than 6 km, it was 10 milligrams. If it was more than 6 km, it was 20 milligrams. Then followed up over 1 month. Then subsequently, there were visits at every 3 months. Looking at the GFR, decline of the GFR, looking at the cardiovascular endpoint, looking at the potassium. And it was an event-driven study. So once the total number of events were achieved, the study was stopped. The baseline characteristics was that the HbA1c, this is for the fidelity, the pooled analysis, it was 7.7%, as for the Fidelio epinephrine as well as the placebo group. Urine albumin excretion rate was seen around 500 milligrams. And also interestingly, there were almost 6% of patients who were at SGLT2 groups. So what we should understand is that when the study was distributed in 2014 and it was completed in 2017, subsequently published, SGLT2 had just started coming in. So that's why a very small subset of patients were on SGLT2. So this is what the fidelity shows. The mean GFR was 57.6 and the mean albumin, urine albumin creatinine ratio was 550 milligrams. Let's look at the results. The composite renal benefits, looking at the right end of the slide, Pindolone significantly reduced the risk of greater than 57% eGFR in kidney composite outcome by 23%. This 57% is akin to doubling of the ceiling effect and has consistent significant effects on the outcome components. So look at all the components. Extreme right is the 57% kidney outcome. The kidney failure, end-stage kidney disease, the GFR declined by 15 and renal death. All of them showed improvement. The risk ratio came down in all the groups, excepting probably renal death. Now, this is just in a slide form. This is showing us the Pindolone. It was shown that the risk ratio came down, the hazard ratio came down to 0.77. So there was a 23% risk reduction as compared to placebo. For all the 3 important kidney endpoints, this was time to kidney failure, sustained 57% decrease in GFR from baseline or renal death. Looking at all the components of the kidney failure, look at the forest graph, all the hazard ratio was less than 1, and all of them were to the left side of the midline, showing that there was a benefit of Pindolone in all the renal endpoints as compared to placebo. Next, let's look at the cardiovascular benefits. Again, the fidelity analysis showed that this reduced the cardiovascular outcome by almost 14%. Looking at the right side of the slide, again, the cardiovascular key components, it showed that there was 14% reduction in the cardiovascular death, non-fatal MI, non-fatal strokes, and hospitalization because of heart failure. Again, these also the improvement. Looking at the cardiovascular events, this was regardless of the baseline GFR or the urine albumin creatinine ratio, or the use of SGLTs or GLP-1 agonists. So looking at the baseline eGFR less than 25 and 25 to 45, 45 to 60 and 60, looking at the baseline urine albumin creatinine ratios, looking at the baseline SGLT2 and looking at the use of GLP-1 agonists. All the hazard ratio again on the left side of the midline, showing that this was beneficial to the group of patients. Again, this was composite data. It showed that the composite cardiovascular outcome occurred in 825 to 12.7% patients receiving Pindolone, and as compared to 14.4% receiving placebo, there was a hazard ratio of 0.86, which translated to 14% risk reduction with low confidence intervals of 0.78 as to 0.95. Efficacy outcomes, again, it showed that the renal efficacy outcomes is eGFR, kidney failure, time to end-stage renal disease, sustained decrease in the GFR less than 15 mm, and sustained decrease in GFR by decrease of more than 57%, and renal death again it showed that the cardiac issue was less than 1, showing that this drug was beneficial in this group of patients who were given. Looking at secondary key outcomes, looking at the albumin-creatinine ratio, there was some benefit in this, showed that the documented mean albumin-to-creatinine ratio at baseline, Finrazone came down to 798 as compared to placebo, which was 814, which was significant. But this was associated with 31% greater reduction in the urinary albumin-to-creatinine ratio baseline at 4 months as compared to the baseline. Adverse effects, your most important adverse effect that you're looking at was hypokalemia. So the maximum difference, kindly note, is very important, was only 0.1 millimoles at the end of 4 months. Lower one is for the placebo as compared to Finrazone. So Finrazone was slightly higher, but also importantly, it was seen that it was seen around 12.1% of patients as compared to 5% of patients with placebo. But importantly, the adverse outcome, the hyperkalemia leading to permanent discontinuation was much less, and hyperkalemia leading to death was nil. So the hyperkalemia occurred slightly higher amount, but it was not very severe, not leading to a discontinuation or because of death. So this is the strategy that was followed, that you start Finrazone and look at the serum potassiums. One more important baseline is that the potassium was less than 4.1 at the initiation. If the GFR is less than 60 ml, start at 10 milligrams, more than 60 ml, go on to 20. Treat with Finrazone. If the patient's potassium is less than 5.5, continue. If the potassium goes up by more than 5 points, stop it temporarily. Once it's come down, then you can restart with a lower dose. So, yeah, I'll just one. So basically, the 2022 updated KDIGO guidelines suggest that the level of evidence is very good, so they given it at A, and the recommendation is 2A. So the KDIGO 2022 updated guidelines suggest using Finrazone with a 2A's recommendation for this. So finally, the take-home message: it reduces the risk of kidney disease progression as well as the cardiac outcome in patients across the spectrum of kidney disease, and is a welcome armamentarium to our group of patients who are exposed to RAS and SGLT2s. And finally, tomorrow, looking forward to going to Nathula Pass. Thank you very much.
Thank you. Thank you very much for a very clear presentation. You clearly mentioned that it is beneficial for kidney as well as heart. Almost 23% reduction in the progression of kidney damage. The only question is how many patients were taking SGLT2 inhibitor?
Yeah. So since this study was instituted very early, it started in 2014 and it was published, I think, ended in 2017. By that time, SGLT2s were not much in the market. So only 6 to 7% of patients were on this.
Yeah, that is the only thing you can see, that you give ACE inhibitor, you protect the kidneys. You add SGLT2, you protect the kidneys. But here, after ACE inhibitor, all the patients were given liberal ACE inhibitor. Yes. Added was Finrazone. So whether Finrazone will be beneficial even after adding SGLT2, that quite I think possibly.
Yeah, so
I think at the moment, whatever numbers were available, whether they have analyzed that, whether they were on SGLT2 inhibitors or they were not on, the beneficial effect of Finrazone was similar. So at the moment, whatever evidence is available, obviously, I think real world data will come where people will be on all these drugs and probably our evidences. And I think future studies also in this direction when SGLT2 is more and more being used in these patients. I think the greatest hope for a nephrologist over the last decade has been, for 2 decades, we were orphaned. Except ACE or ARBs, we did not have an evidence-based medical treatment for chronic kidney disease. And most of us were, to some extent, forced to use non-evidence-based drugs, increase just the drug burden of the patients, but there is no real beneficial effect on the progression of kidney disease, whatever parameters.
But now, over the last decade, you have three molecules which have come, two molecules which have come, SGLT2 inhibitors and the finerenone. So finerenone has been approved by DCGI, I can tell you that, and it's soon going to get marketed in India. So you're going to be using this drug more and more often. Obviously, as a nephrologist, I think it's worry remains hyperkalemia we get, but you must know that hyperkalemia is a clinical worry. It happens even with all these drugs. It happens in less than 10% of patients. The reason you get scared of it is that it can cause fatal event, and that's why you do not want to be blamed for that kind of a fatal one. But 90% of your patients will be benefited and will not have severe clinically important hyperkalemia. So do not be afraid of using these drugs just for the fear that overall, even when these have been included in the studies, not more than 10% of people have been have had clinically important, more than 5.5. I'm saying that's the study data. Clinically important, I think probably. I don't get worried till about 6 millicoulomb or so personally, but I know each individual, each nephrologist will have a threshold of where your clinical worries would go. But I usually am fond of using ACE or ARBs. I'm fond of using SGLT2 inhibitors now. And I look forward to having another drug which will be useful in patients in retarding. And there is evidence for these large number of patients. You look at the number of studies, the number of patients which have been included in the kidney studies previously. 100, 800, 600. Now you are talking of these 5,000, 6,000, 7,000 patients. And this is what is happening now. And that's the reason why these studies are producing this clinical evident based kind of thing. Any questions? Yes, Ashwini.
Yeah. And Dr. Balla, from the data presented from these studies, could they pick up any difference in its effect between proteinuric CKD and non-proteinuric CKD?
So see, this is only data in patients with diabetes. They've not taken it to non-diabetics.
SGLT2 inhibitors, you can see that most studies, the lowest level of albuminuria was 200 milligrams or so, going up to about 5,000. Yeah. So 200 to 5,000 milligrams of albuminuria. These studies have, the fidelity trials are predominantly in diabetic patients. The SGLT2 have been used in non-diabetic patients as well.
So if you break down the data, the Fidelio study was basically in diabetic CKD, and they looked at the renal endpoints. Now, since Fidelio is, the fidelity is pooled of Fidelio as well as Figaro. If you talk only of the Fidelio, the proteinuria was slightly higher. It was 854 milligrams, but only diabetics. So that you have to be clear. So we have no data on non-diabetics. Maybe there is a trial going on. You know, we had a online symposium with Dr. George Bakris on Sunday. I was there to that. So he was also very, because he was looking, said that this could be a drug in patients with heart failure, because they've excluded patients with heart failure, hospitalization with heart failure. That is, they've not taken patients with low ejection fraction. They're trying to introduce that. They are excited about this drug. So that is, yeah.
Only one. How does it decrease albuminuria when the primary site of action is the distal convoluted tubule? And secondly, you see the classical teaching is that aldactone, trimethrin, these type of drugs should not be used when the creatinine is 2.5 plus.
So yeah, so this was a question that is when they were designing the trial. So it is a non-steroidal drug, short half-life. Because of the short half-life, the effects on the DCT remain less. They do not completely block the sodium channels, so there can be some excretion of potassium, right? Plus, what this question was asked to Dr. Bakris repeatedly, he said that there may be some, influences at the gene level that may be causing a less incidence of hyperkalemia. So that is what
effects on proteinuria could be multifactorial, not necessarily that it is because of the effects on the metabolic effects, and the inflammation is what causes progression of kidney disease and increase in albuminuria as well.
So the MR receptors are present on the mesangium as well as on the podocytes. Maybe that is causing inflammatory and
so there would, theoretically it's possible, but we don't know yet the full. Yes.
If the mechanism of actions are same are similar with mineral cortical receptor blockers like epinephrine and all, then how the hyperkalemia is less? And if you say that it's a shorter acting drug, but you are giving it once daily dose, how will it have a 24 hours coverage?
So this is a persistent question that is coming up, that okay, the effects are the same, but the side effects are more with spironolactone and albuterol. Steroidal versus non-steroidal. I'm sorry I didn't put that slide. Steroidal versus non-steroidal effects will be same, but the degree of side effects is much more. The sexual side effects, gynecomastia.
Did they propose any mechanism for having less side effects in terms of sexual side effects or?
Just wait. You are going faster than what we know at the moment. And I think you will have newer mechanisms. Look at SGLT2. Look at the mechanisms which are being unfolded. So we will have more evidence for that. At the moment, I don't think people know it.
So as far as the hyperkalemia goes, we are saying effect on the DCT, plus what they're trying to say is that there may be some genetic or basic changes in the genetic thing which may lead to a decrease in the hyperkalemia.
I think we will stop here. A lot of questions need to be answered in this spectrum. How the proteinuria decreases, why the hyperkalemia is less. I think time will tell this. We come to the third presentation. That is, as we discussed, ACE is very beneficial, came into line almost 25 years back, 20 years back. And this has been the lifeline, and all nephrologists are using it. After AKI, as I said, the trial is still going on, START or not trial, but there is some data, and Professor C. Arvind, I think again, a brilliant nephrologist who is more digital than any of us. Yeah, so he is going to talk, again, an excellent speaker and an intelligent nephrologist. He is going to talk, should we stop ACE or ARBs after AKI?
I wish to thank Professor Kher and Professor Verma for inviting me to speak, and Microlabs for inviting me here. Just to let you know that I bought this dress today. It is belongs to the Lepcha tribe. There are two tribes in Sikkim, the Lepcha and the Bhutia tribes. The Lepcha tribe wears this as one of their Tokrodam sort of dresses. Bought this in a handicraft shop today. So basically, we are looking at ACE inhibitors and angiotensin receptor blockers. They've been cornerstones in therapy, perhaps now being upstaged by the SGLT2 inhibitors. Slow progression of proteinuric disease, that's one of their characteristics. And obviously, they markedly improve patients with HFrEF, the prognosis of these patients, especially with HFrEF. But the problem is when there are patients with AKI, do they actually cause or exacerbate AKI, and should we use them in this situation? And that supposed causal contribution of ACE and ARB to AKI means that we're going to stop these drugs whenever there's an intercurrent illness, or even a surgery, or heart failure sometimes. And the patient gets discharged without the drug. And does the patient actually ever come back onto that drug is the question. And sometimes that doesn't happen. If that doesn't happen, what is the problem? So I'm going to just put up 4 or 5 studies on what could happen if you don't restart AKI. And then it's up to, again, like Professor Verma mentioned, you need studies that are randomized controlled. So let's look at some of these studies. Most of them are cohort and observational studies. This is a study on preoperative renin-angiotensin system use linked to reduced acute kidney injury. Systematic review this is. 24 studies, 1 randomized control and 23 cohort studies with 102,667 patients. Meta-analysis of the RCT and 11 studies with a propensity score analysis demonstrated the pooled relative risk of AKI in patients receiving these is 0.92. So it's less than 1, it's better. Within the selected studies, preoperative RAS inhibitor therapy was not associated with a significant increase or decrease in mortality. So the meta-analysis demonstrates an association between preoperative RAS inhibition treatment and lower incidence of AKI. Like I said, anything below 1 is good, and this is 92, that's about 8% less. Moving on to December 2018, and you have this second trial that Sandeep Brar and co did. So this was a retrospective cohort study using data from the Alberta kidney disease network population from Alberta in Canada. This is for about 7 years, as you can see there in adults. All patients who survived to hospital discharge were followed up for a minimum of 2 years. The exposure was use of an ACE inhibitor or ARB within 6 months after hospital discharge. That was the exposure. 22,193 patients were prescribed an ACE or ARB within 6 months of discharge. And after adjustment for comorbidities, the use of ACE or ARB was associated with lower mortality in patients with AKI after 2 years. Hazard ratio of 85 means 15% lower. However, patients who received an ACE or ARB had a higher risk of hospitalization for renal cause. That could be AKI or hyperkalemia. No association was found between ACE or ARB use and progression to ESRD in this particular trial. So among patients with AKI, ACE or ARB therapy appeared to be associated with a lower mortality, but a higher risk of hospitalization for a renal cause. So there's a potential benefit here for ACE or ARB use after AKI, but you need to be monitoring these patients cautiously, especially their creatinines and potassiums, to make sure they don't get admitted. Now, this was a trial from a UK group, and this is basically looking at risks and benefits of temporarily discontinuing medications to prevent acute kidney injury. So they looked at adults taking diuretics, ACE inhibitors, angiotensin receptor blockers, direct renin inhibitors, and NSAIDs, as well as metformin or sulfonylureas. And looking at these primary and secondary outcomes that were outlined there, we're not going to look at those drugs, but we will look at the trials that looked at ACE and ARBs. 6 trials, including 1,663 participants. 3 of them were randomized controlled trials. Mean age, elderly, 65 to 73, and the proportion of women, 31 to 52%. 5 evaluated the discontinuation of medication prior to coronary angiography and 1 prior to cardiac surgery. Here, there was an increased risk of AKI of around 15% in those whose medications were continued compared with those in whom it was discontinued. Relative risk of 1.17%. So, in this study, we are looking at withdrawal of ACE or ARB in this select population who underwent angiography and cardiosurgery may reduce the incidence of AKI, but no evidence of the impact of drug cessation on AKI incidence during intercurrent illness in primary or secondary. Now, this is the national guidance from the United Kingdom on change in renal function associated with drug treatment and heart failure. And this is quite interesting. I'm not going to go into this in much detail, but I'm going to show you this table. And in this table, if you see the right-hand side of the table coming to HFrEF, as compared to the middle column, which shows HFpEF, that is preserved ejection fraction versus reduced ejection fraction. Reduced ejection fraction is anywhere below 40, preserved is anywhere above 50, 40 to 50 is a gray area. So whenever and this is a recommendation by their national group. Whenever there's an increase in serum creatinine by 30% or by less than 30%, in the HFPF, they consider stopping ACE, ARB, ARNI, review MRA doses, whereas whenever there is reduced ejection fraction, they advise you to continue unless there is symptomatic hypotension. When there is an increase in serum creatinine of between 30 and 50%, they just say stop, please stop. But when it is in preserved ejection fraction, but in reduced ejection fraction, they would consider reducing the dose or temporary withdrawal. So obviously, you're looking at areas where with reduced ejection fraction, these drugs matter and you would want to actually continue these drugs. This is quite a big study from, again, population-based cohort study from the English and Swedish population. Laurie A. Tomlinson, the lady mentioned at the last, has been doing a lot of work in this area, and there's a lot of literature attributed to her and Charlie Thompson. Both of them are in the UK. So these authors conducted 2 parallel cohort studies in the English and Swedish populations between 2006 to 2016, using multivariate Cox progression and estimating hazard ratios. They looked at hospital admission for heart failure, AKI, stroke, or death within 2 years after hospital discharge following a first AKI episode. And they compared the risks of admission between people who stopped ACE or ARB to those who have prescribed ACE or ARB within 30 days after a discharge for AKI. So in England, there were 7,303 patients who were included with AKI hospitalization. 4,003 were classified as stopping AC or ARB based on no prescription within 30 days of discharge. In Sweden, 1,790 patients were included, of whom 1,235 or 69% stopped treatment. In England, there were no differences seen in subsequent heart failure, AKI, but there was an increased risk of death in those who stopped AC or ARB compared to those who continued. So it's quite important. Results were similar in Sweden. No differences in risk of heart failure and so on. No increased risk of death, however. But stroke was less common in those who stopped AC and ARB. So a bit of a dichotomy there. So they concluded that previous AC-ARB users who continued treatment after an episode of AKI did not have an increased risk of heart failure or subsequent AKI compared to those who stopped. The English population, however, there was an increased risk of death for those who stopped AC-ARB compared to those who continued it. This is another study, quite a recent study that's come out in the most recent study that's come out in Jan 2022. Stopping versus continuing RAS inhibitors after acute engineering. Again, this is an observational study. So they analyzed outcomes of RAS users experiencing AKI in Stockholm and Sweden. It's different from the other group. Compared RASI within 3 months after discharge with stopping with continuing. And the primary study outcome was composite of all-cause mortality, myocardial infarction, and stroke. 10,165 individuals were in the study, 4,429 stopped, 5,736 continued. Median age is quite high, 78 years here, 45% women. And after waiting, they found that those who had stopped had an increased risk of the composite of death, MI, and stroke compared to those who continued, with a similar risk of recurrent AKI and a decreased risk of hyperkalemia. So they concluded stopping RASI use among survivors of moderate to severe AKI was associated with a similar risk of recurrent AKI, but a higher risk of the composite of death, MI, and stroke. So basically, you're getting a pattern here which says that perhaps we should continue it rather than stop it. And if we don't continue it, you're looking at an increased mortality. In this particular trial, you're looking at increased risk of death, MI, and stroke. So I'm going to stop there after those 5 studies, and a tongue-in-cheek moment for you folks. When would you actually use ACE inhibitors in the treatment of AKI? And the answer is scleroderma renal crisis. The scleroderma renal crisis occurs in 5% of patients with scleroderma. Routine use of ACE inhibitors in this condition has been reported to dramatically improve outcome. Fall of 12-month mortality from 76 to less than 15%. This is USA literature. And captopril has been mainly used because it is short-acting. So in conclusion, and I'm only going to read, that we need trials that are randomized controlled trials that will distinguish between the structure and hemodynamic sort of AKI, because structural AKI is bad. Hemodynamic AKI, they call this permissible hypercreatinemia. And if we're able to distinguish that, that would be fine. So until such trials have been performed, clinicians will continue to use clinical reasoning rather than guideline-based reflexes to decide on whether we use ACE inhibitors or ARB. Should we stop it after a problem? Should we stop it after a small change in creatinine? In a patient where there actually is strong evidence, especially in certain subgroups like, let's just say, HFrEF, where there is really strong based evidence for long-term use of the drug. I'm going to stop there. Thank you.
Thank you very much. I think you have done a wonderful job for the debatable topic. And because there are many variables in that, people who have got heart failure or who require ACE inhibitor, possibly that is a group who should benefit if ACE ARBs are continued. Possibly patients who are healthy, nothing is there. I don't know what is the answer for that. The message we don't know at the moment, unless we have got a controlled trial, which is ongoing at the moment. So possibly the available data shows that if you continue, there is no risk of, rather the risk of death, MI is reduced, stroke is reduced. There may be a risk of increased hospitalization due to AKI. That is what it is now. Any questions, comments?
Suppose I don't stop, there is the chance of getting an AKI increase, but and the rate of recovery
No, we can't answer the question. We don't know the answer to that question. So really, quite frankly, there are so many variables there that how much contrast did we use? Was the heart function good? Was there a reduced ejection fraction causing problems? What about the hemodynamics of the patient? So it's very difficult to answer the question. So the answer is we still don't know.
But theoretically, I'll also do what you will do. That knowing it, that a person who is going for angiography, he has got a poor ejection fraction. And if I continue giving ACE inhibitor or all, I am reducing the filtration fraction. Possibly, I may help in causing AKI. I will also stop at that moment till the time I have got a definite answer.
See, the problem is what we have been traditionally practicing is also based on not much evidence. What you are doing is not based on a lot of evidence. If you look at critically what you are doing, there isn't any evidence to say that you're doing right. But the question is, more important question is, even if you decide to stop it, because you can have an individual opinion, I cannot question that opinion because there's no evidence contrary to that also. So restarting is the most important thing, which clinicians forget and patients do not get, because the very fact that he was on ACE inhibitors was for reducing mortality. See, most of us are worried about AKI. You're not worried about what it does to the mortality. It always has, most of the time, it has reduced mortality. And that's important. If the person is not surviving, reducing AKI doesn't make that much of a difference. That's important. No, I think we can, the question is, we will not be able to sort it out. You and I will discuss it after dinner. Yes. I will. Yes, I think. If you have stopped, restart it. Make a calendar that you're going to start it. That's all.
And that is also the advice of the Renal Association, British Society of Heart Failure. If you look at that HFREF column, they're very concerned about stopping ACE inhibitors, even if the creatinine goes up. So you have to be quite careful.
Thank you. It is going to remain debatable, as you said, and I think thank you very much, Arvind, for that exceptional, very good lecture. We move to the next session, and I think we are still running late. Dr. Sanjeev Gulati is well known to everybody, and Dr. Sanjeev Gulati is the incoming president of the Indian Society of Nephrology. I hope he does become international president of the International Society in the near future as well. He is a competent guy, and he is the chairman of nephrology at the Fortis Group of Hospitals, NCR Delhi. And he practices both adult and pediatric nephrology and is a very good speaker. I will only request Sanjeev he's given this talk earlier also, I've heard him on this talk, but he needs to reduce this talk to 10 minutes so that we can have a panel discussion on this. There are a lot of practical issues there with all the talks. So Sanjeev, all yours.
Thank you, Professor Kher and Professor Verma, for this invitation, and it's a great pleasure to be here in this scenic part of the country. I'll be talking only about the pathophysiology of anemia, and later on there's an eminent panel which can debate as to which molecule they would like to use. But first of all, when you talk of anemia, one is reminded of this quote by Alvin Toffler. I read this quote from late President Kalam's book, Wings of Fire, and very true that illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn. And in that sense, over the last 2 decades, we have really had to unlearn the past management of anemia, which when we were started my DM was mainly in terms of blood transfusions, and we have graduated on to more complex therapies, and the new therapies continue. But I'll share with you a case which I've been following. This is a 24-year-old male. He currently is based 63.9 kg. He's done his BTech. He's employed in a multinational. His hobbies are cricket. He cycles. He does an annual trek to Vaishno Devi, which some of his peers may not be able to do it. Why am I telling you this story? He had chronic kidney disease at 2.5 years of age. His hemoglobin consistently, since he has been very compliant and very regular in a follow-up, has been between 10.7 to 11.4. Needless to say, with the use of erythropoietin, serum creatinine on last follow-up was still 4.5. So we have been counseling him about kidney transplant, and EGFR is 18. So as you can see, over the last nearly 22 years, there's been a very, very slow progression of kidney disease, and the quality of life is better than some of his peers who are healthy. So this is the global CKD scenario. The global CKD prevalence is about 9.1%. About 5% of stages 1 and 2, 3.9%, stage 3 and 4 is
therapies. So these are the pathophysiological anemias of mechanisms of anemia of inflammation, which we see in a significant number of patients. There is an activation of immune cells, release of inflammatory cytokines. The interleukin 6 acts on the liver, further stimulates hepcidin, and this is what it does. As I told you, there's a tumor necrosis factor alpha, the host of other interleukin cytokines which act at different cells and contribute to the anemia of chronic kidney disease. A word about iron deficiency in CKD patients. These are the patients with non-dialysis dependent chronic kidney disease, 17%, 48% in CKD stages 3 to 5. These are patients with CKD prior to hemodialysis initiation, 28.4%. And this is the low iron indices that are prevalent in these patients. So iron deficiency remains a very important part of our therapy. And now patients with CKD anemia often require interpretation of iron parameters like T-sat, serum ferritin. There are issues with the ease of iron administration, intolerance of some of the oral iron agents that are available for non-dialysis CKD patients, concerns regarding potential toxicities of high doses of IV iron in patients receiving hemodialysis. So a significant number of patients of chronic kidney disease actually have a functional iron deficiency because of the close interrelationship between hepcidin and inflammation. And this is reduced renal clearance of hepcidin, the inflammatory markers leading to cytokines, increased iron stores in the liver, increased release of hepcidin, and interfering with the release of iron from the macrophages, interfering with the release of iron from the liver, and reduced absorption, creating a functional iron deficiency state, which we need to keep in mind when we are approaching any patient with anemia and CKD. So another study from Kidney International, which showed an increased mortality risk associated with abnormal iron status in diabetic and non-diabetic veterans with pre-dialysis CKD. They concluded that abnormal iron balance, particularly functional iron deficiencies, are associated with increased mortality in CKD, and the mortality risk was similar between the diabetic and non-diabetic subgroups. So there are barriers to ESA use in non-dialysis CKD patients. Requires parenteral administration. Limited healthcare patients are not comfortable using it. Some patients may not be seeing a nephrologist. Target hemoglobins in ESA levels and requirement of medical healthcare facilities. These are the unmet needs with current therapy. As far as ESAs, there is a subgroup of patients, we all see that, who are hypo-responsive. And there's a progressive reduction in response. In this subgroup of patients, studies have shown there's an increased risk of adverse cardiovascular events like hypertension, stroke, thrombotic events, MI, heart failure-related hospitalization, all-cause mortality, cancer progression, diabetic retinopathy, pure cell aplasia, and anaphylactic reactions. Concerns, especially with IV iron, are bacterial overgrowth, severe GI side effects, hypersensitivity reactions, increased risk of infection and mortality, and cardiovascular risk. So these need to be kept in mind whenever we are prescribing our therapies. As I said, there is inflammation, diabetes, cancer in patients who are a host of factors, in patients who are hospitalized, in patients who have received a kidney transplant. Anemia continues to be an important issue, especially in the subgroup of patients who have chronic graft dysfunction. And it has shown that there is an increased risk of death, loss of graft function, as well as congestive heart failure. High dose ESA may not improve the short-term allograft function, and long-term ESA function may prove, ESA administration may prevent progression of allograft nephropathy. Again, cold chain maintenance is critical for the ESA administration, right from the manufacturer, distribution, arrival at the facility, storage and handling down to the administration. And we need to re-emphasize this to our patient at each and every visit. These are some of the breaches that can happen. These are the FDA warnings with the use of ESA, as I showed you from the COIR and the TREAT study, not to exceed the target benefits. A word about the ESA resistance to hypo-responsiveness. The hepcidin-induced iron mobilization issues compounded by underlying inflammatory conditions, hypoalemia, seen clinically in various studies, about 10 to 20% of patients. You are using escalated doses, you are not seeing corresponding benefits. So that's the time that you should look at hypo-responsiveness, investigate.
Definition is a use of greater than 300 international units per kg per week of erythropoietin or 1.5 mics per kg per week of darbepoetin. And this hypo-responsiveness contributes significantly to mortality, morbidity, healthcare economic burden in chronic kidney disease, and represents an important diagnostic and management challenge. The two causes, there's a host of causes, but the two causes that you need to focus on are absolute or functional iron deficiency and inflammation. So this is again the burden of ESA hyper-responsiveness and the difference between the responders and the ESA hyper-responsiveness and normal-responsive patients. As you can see, the iron doses, the ESA use, the PTH levels, hemoglobin levels are lower. The transferrin saturations again are lower in this, and the ferritin levels are, as understandably, are much higher. So compared to normal-responsive patients, ESA hypo-responsive patients face the following changes: significant higher dose or requirement of IV iron and ESA. They achieve lower hemoglobin level. They have a worse iron metabolism, significantly higher ferritin, and lower transferrin saturation, which we do see in a subgroup of patients. It's a study published in Kidney Medicine 2020 about how does ESA responsiveness affect clinical and economic outcome, and what they concluded was that ESA hypo-responsiveness in dialysis patients is associated with higher mortality, higher cardiovascular hospitalization rates, and healthcare costs. So if you have to look at management of anemia of CKD in patients with inflammation, we need to consider both the causes of systemic inflammation, the exacerbation of anemia of CKD. Inflammation is indicated when you have ferritin levels that exceed more than 500, accompanied by a decrease in hemoglobin and transferrin saturation levels. And for maintenance of hemoglobin levels, you require much higher doses of IV iron or ESA, and IV iron and ESA themselves contribute to increase in the hepcidin production, which is quite a paradox. So we come back to this patient, 57-year-old male. What would be your choice of ESA in today's scenario? This is another patient. This is a 57-year-old lady, 62.7 kgs, CKD stage 5D, hemoglobin of 7.8, T-sats of 28%, ferritin of 3,248. I saw her recently. And what would be your choice? And I leave this to the expert panel. So to sum up, anemia in CKD is an independent risk factor for CKD progression. Current standard of care, that is iron supplementation and ESA injections, have certain limitations. Hyper-responsiveness is a big concern. There is an unmet need for answering the challenges. And we also have HIF, PHIs. So how would they factor in today's therapy versus the time-tested ESAs? That is for the panel again. Thank you so much.
Thank you, Sanjeev, for starting that. And we will have, so I invite the panelists who are going to be here. And the panelists are Dr. B.S. Solanki. Dr. Solanki, can you come in? Dr. Solanki is the senior nephrologist at the Permanent Hospital in New Delhi. Yeah, can we get the chairs now on? Why don't you come? Yeah. Yeah, then Dr. Ramesh Jain. Dr. Ramesh Jain is Ramesh Jain works as senior consultant hospital at Saroj Hospital, Rohini. Dr. Ramesh, yes. And then we have Dr. Deepak Kalra. Dr. Deepak Kalra join us. Dr. Deepak Kalra is the head of the department at nephrology at the Fortis Hospital, Shalimar Bagh. Then we have Dr. Sandeep Gupta. Dr. Sandeep Gupta is the senior nephrologist at, he works at 2-3 hospitals, Goyal Hospital and Dr. Krishna Nagar, Goyal Hospital at the Krishna Nagar. Yes. Dr. Manjunath is a senior nephrologist at Sparsh Hospital in Bangalore. Dr. Manjunath. And then Dr. Sandeep Chauhan. Dr. Sandeep Chauhan is a senior nephrologist who works at the Ganganagar Hospital. Ganganagar. Yes, Sandeep. So we have an elite panel, and I think Dr. Verma has questions for all of them.
Yes. I think we can start from Dr. Deepak Kalra. In your experience, how many patients on your dialysis program have got functional iron deficiency? And for the sake of repetition, when do you call it is functional iron deficiency?
Functional iron deficiency is seen in around 20% patients. Around 20% patients we see in dialysis that they have functional iron deficiency. So in spite of the indices showing that iron is replete, they have transference saturation which is more than 20 to 30%, and the serum ferritin levels also are more than 500 to 800, and still they do not respond to the usual doses of erythropoietin or even the higher doses to around 300 units per kg of subcutaneous dose of erythropoietin per week. Still, they are not responding to their anemia is not responding adequately.
So what do you feel, Dr. Manjunath, is the cause for this functional iron deficiency?
Most common is inflammation, sir. Inflammation can be like CKD as such is a inflammatory status. It's mainly it's the inflammation, generalized inflammation, what I see. Though we at the same time the inflammation, what the main factor which plays a role in the unresponsiveness to the ESM, and at the same time the functional iron deficiency, what is defined by our colleague, that's the main reason what I see.
But I think Dr. Abeshkar said, how can we combat this? If a person is iron replete in your mind, there is good amount of ferritin, TSAT is low. How do you combat? What is the program? How do you go about it?
You see, we need to revise the whole thing again. We need to see the other causes of anemia other than the iron deficiency. If the patient is not responding, there's a replete iron stores are adequate, ferritin more than 500. And you see, and then we think, either we are missing something else, say B12 deficiency, folic acid deficiency, or other issues. We also look into the other causes of hypo-responsiveness under the same circumstances, like hyperparathyroidism. So I have seen that many of the patients with hyperparathyroidism also do not respond adequately in spite of being replete with the iron stores. Then if we rule out all other causes of hyper-responsiveness and we say that it's functional iron deficiency, then we need to really look into, as Dr. Manjunath has told, is about the inflammation. So the other causes, like, inflammation may be like ongoing, any autoimmune disorder going on, maybe some hepatic involvement is also there, leading to CLD, SCV related CLD is there, SCV related active infection is there. There may sometimes be, leads to hyper-responsiveness and in a functional iron deficiency. Then we need to really look into, now there's a new kind of new molecules are available, which really leads to the blockage of hepcidin. So thereby improving the availability of iron. And before that, I used to use vitamin C to improve the availability of iron in a functional iron deficiency state, which sometimes helps us in really after achieving the almost all the form of treatment available. Now let us see, how the HIF can really help us. I have no good experience about that. Yes.
I think so far the panelists are accepting that approximately 20% of the population is hypo-responsive. And we say hypo-responsive if the requirement of erythropoietin is more than 300 units per kg body weight per week. If you are giving subcutaneous, it is 450 units. So that much of erythropoietin, if it is not able to raise hemoglobin by 1 gram in a month, we are saying the person is hypo-responsive. And we agree that hypo-responsiveness is due to some underlying, whether due to some infection, and the marker may be CRP you are doing. And secondly, maybe hyperparathyroidism, maybe because they are also causing refractoriness, and previously used to be aluminum overload, etc. They also were adding to that. So if it is there, the question is what to do. If the problem is so much 20% of the population is having, I think Dr. Solanki, what is your viewpoint? What should we do now if that becomes a problem?
I may also add that, would you give iron still to these patients, say somebody who has got a ferritin of about 700 or 600 and saturation about 24%? So do you think that iron would still help in this patient? Although ferritins are reasonably good and the iron saturation is not also that poor.
Okay. So usually this kind of problem happens in a population who are on maintenance hemodialysis from quite a long time. Either they are iron loaded or they have a very high ferritin level with the normal or a low transferrin saturation. So even after intensive investigation, we didn't get any direct evidence of chronic infections. Most of the time, either it's some patchy ulcers in the GI tract with occult positive, or they have history of inadequate erythropoietin. But as sir said, the person who is having very high ferritin level, usually
The question was, ferritin is 700, saturation is 24.
Yes, sir.
Should we give more iron?
Yes, sir. At this point of view, usually we don't give. Timing we manage with the blood transfusion. Though recent guideline discourage the use of vitamin C, carnitine, but we keep on using this agent, and sometimes
Guidelines do not recommend.
recommend.
The vitamin C,
Yeah.
the guidelines do not recommend.
Yeah.
The pivotal trial, which came, they have used iron, even if the ferritin is 700 or up to 800. They took it. And if the saturation is, they went up to the saturation of 40%. And they found that by giving 400 milligrams of iron every fortnight, that by giving iron, you can still improve the hemoglobin, and possibly that may be removed.
So,
Important to give that guideline that using IV iron, intravenous iron in these patients who have that borderline zones of iron and all, because of the inflammation, we are not able to sort of apply intravenous iron does help in taking their hemoglobin, getting them without blood transfusions in these patients.
Now let's say HIF inhibitors.
Yes, sir.
Now a person like Professor Gulati mentioned, the ferritin is 2,600.
Yes, sir.
Saturation is, let's say, 35, 36%, 40%. You have taken 40%, that is high. You have tried to find out a cause of inflammation, any like tuberculosis or any infection, it is not there. You see hyperparathyroidism is stable. With the availability of HIF inhibitors,
Yes, sir.
should we try it?
Yes, sir. In this kind of patient, probably hepcidin plays a role. So the use of HIF is quite appealing. But then we have to balance it out against the, uric gut with exhausted kidney toxins. We really need to answer all this question before the use of HIF comes into routine
Now
use.
the next question will go to that in which patients you will not like to use HIF inhibitors?
Patient with iron.
Inhibitors are of senior, one of the companies is there, and the disability that is there, and people are using it. And if we are not asking the experience, the audience will give their experience. But we will like to do, we like to use with any benefit.
I don't have much of experience with but I'll certainly prefer to use HIF inhibitors in those patients.
Yeah. Now, which patients, now, they say we want to use HIF inhibitors. Well, what you have excluded other causes, which patients you would not like to use HIF inhibitors at this stage?
Sorry, sir, I have no idea about this. So I will put.
The trials have been clinically sort of used in a clinical trial. They have excluded the patients with autosomal dominant polycystic ovarian. Here is the dominant that when you have these hypoxia inducible factors, they do not only activate because it gets into the nucleus and then is a transcription factor and it activates many other factors also. And some of the factors might be sort of angiopoietin-like or growth factors. They increase angiogenesis, or they might increase cell proliferation in polycystic kidney. So there is a fear that there may be increased chances of malignancy. So patients with malignancy, past history of malignancy have been excluded. Patients with severe diabetic retinopathy have also been excluded in these trials because there is a fear that there may be an increased incidence of severe retinopathy progressing. So in the trial, people obviously pregnancy and all those other questions, children have been excluded so far. Elderly population has also been excluded at this point of time. So these are the usual exclusions in these patients so far. So at this point of time, since there isn't any clinical evidence in favor of these, so these would remain to be still that you do not. If you have a patient with polycystic kidney disease with chronic kidney disease, do not. If you have a patient with diabetic nephropathy with severe retinopathy, be aware that there is complication. So obviously, other patients, regular chronic glomerular nephritis, other problems, there isn't any past history of malignancy or anything. I would use this drug in a patient where I'm not able to impose because there is resistance and hypo-responsiveness. So that's the kind of thing. Would I use as such in a patient who is not yet started on chemo? Probably yes, in the patient at the moment I'm gaining experience, so I would probably choose patients who are afraid of using syringes because people have to be there is a scare about the injections. So somebody who's not interested, we want to use a tablet. Somebody who's really too far off, but I would want this patient to be kept on contact because this is a new drug. I would want to observe these patients frequently for any other unknown complications. See, all drugs can produce complications prior of a short period of time. We do not know what will happen to these patients. So I have to keep my eyes open for any new complications after these patients. So these are available now. There is good evidence, randomized control trials have shown that they are effective. At the moment, roxadustat has not been approved. It's been approved in China, but not in Japan, but not approved in the US FDA at the moment. That they will now approve the trial. Daprodustat, the ASCEND trial, many of us were part of those, and so they have already published both non-dialysis and dialysis population data and are awaiting US FDA approval. Likely, Denervation, which is an Indian writer, has used it for it's good that an Indian company is to So I think the use at the moment is limited and we don't know much. I think we will go one by one. Your views on any aspect of anemia which we have not covered. I think one by one, the panelists can give their opinion before we go to the anemia management, anything, because whatever has not been covered, you find a problem in your patients.
I just have a question, sir. Though the data with HIF inhibitors has shown that the cardiovascular safety profile is almost equivalent to the ESAs, is there a concern in patients who have a very high risk of cardiovascular profile or who have had a recent MI or stroke in using these newer agents?
No, at the moment, they didn't take patients with acute myocardial infarction as such, but patients with cardiovascular disease. And as nephrologists, you know that all our patients, the incidence of cardiovascular mortality is extremely high in our patients. So most of our patients have high risk cardiovascular mortality. So they did not find it any different. There was no superiority as far as cardiovascular outcomes were concerned, but they were as good as the EPOs, because they were compared with EPO and with darbepoetin, the regular. So those were the ones.
Only that at the moment, if any patient had MI,
recent MI or recent
stroke,
They
in the
haven't-
last 6 months,
they didn't
you will
use.
not take it.
They haven't included these patients.
So
in the
we should
trial.
not be using in
So
these patients.
at the moment, we don't have any evidence whether there is going to be any adverse effects in those patients. No one knows it. Anemia is treated in patients with cardiovascular disease. Anemia is a high risk factor for cardiovascular mortality, high risk factor. So patients with anemia have increased high risk mortality, not only for progression of kidney disease, but high mortality, cardiovascular mortality, overall mortality. So anemia needs to be treated in these patients. Now, whether HIF inhibitors are any going to be better or they're going to be worse, we don't know yet.
The only thing what you find is the level of erythropoietin in blood is much lower in patient where you're using HIF, many times lower. And because of this, now when you used to say that higher EPO dose is cardiovascular risk, so that risk theoretically is less. But again, the data has to come.
Even LDL cholesterol has been shown to be reduced by using.
Drug specific. That is roxadustat and desidustat. They lower cholesterol.
Lower cholesterol.
Because they increase the acetylcholine coenzyme activation. But other ones are not reduced.
I have used in a couple of patients the HF inhibitors, both in dialysis as well as non-dialysis patients, and I have got a good results, just like what you were telling, sir. And at the same time, like in anemia of CKD, as sir rightly told, we have to evaluate for vitamin B12, iron, as well as the folic acid and hyperparathyroidism. What is the role of anti-EPO antibodies? When should we consider doing the anti-EPO antibodies? EPO antibody, when we suspect hypo-responsiveness to EPO, where
That if despite increasing the dose, when we say hypo-responsiveness, despite increasing the dose, there is a drop in hemoglobin. Rather than rise, there has to be a drop in hemoglobin. And retic count has to be pretty low.
Yes.
So people are like to add that. The retic count is low, and there is a drop in hemoglobin. Then you start thinking of that whether there is a requirement to do antibody. That is the time. And unfortunately, these are not available now. Previously, they used to send the sample to US. There isn't any antibody test available now to report. I just wanted to add that you all look at another of the areas, Post-transplant, at the trial, and there was the FDA not given. So I think at the present moment, trying to treat this process. Yeah. Although whichever patient you are doing, have to keep a very good choose your patient. At the moment, no HIF inhibitor is approved by FDA. I think Dr. Ramesh does.
and changing of EPO from EPO alpha to beta, I think it's or Mr. Does it going to pegylated form? Is it going to be helpful in this kind? Like a changing of the EPO from alpha to beta or the pegylated forms in the hypo-responsive patients, does it going to help in
I'm
inhibiting?
not aware that is there any benefit of shifting from one form of EPO to another in patients of hypo-responsive. Any opinion, any comment from anybody? If a person is not responding to one erythropoietin, by changing to other brand or other
Alpha to beta or the pegylated forms, anything, any
I am not
short of HIF.
I don't think there is any evidence that shows that. Have tried using different forms of erythropoietin to have an antibody to say erythropoietin alpha, then using erythropoietin beta has been tried. And occasionally you may have, but those who have different antibodies, but people have tried, and using the alpha-poietin might help with such a patient to have a particular. But if there is resistance, hypo-responsiveness, many factors like iron, all that, changing brands will not help.
I have a patient, sir, who is around 65. I'm facing the problem with hemoglobin. It's always 6.57 despite of giving an adequate EPO, good iron levels, and vitamin B12, folic acid, PTH under control. Really, I have changed, but not getting good results. Probably.
Can just mention about which form of iron therapy you are preferring. Is it
intravenous or oral?
Oral or intravenous? If intravenous, is it iron sucrose or carboxymaltose or isosorbide?
Sir, the iron therapy per se is undoubtedly intravenous over oral and low molecular weight over high molecular weight. So any iron, intravenous iron, which is low molecular weight, is a preferred choice for real use. The problem, as Dr. Gulati really highlighted, that for how much, we can really target the serum ferritin level. Suppose if we have achieved, say, 500 or say 800, so should we really go more with iron? And you see, after really achieving that ferritin target of around 500, I start increasing the dose of erythropoietins to say around 200 units, say 250 maximum, not more than that. Because the majority of these patients will land up in hyperkalemia and severe hypertension, uncontrolled hypertension, even in a patient who are on dialysis or even in a pre-dialytic states. I don't know, till how long, till how far we should really inject IV iron. Say, suppose as Dr. Gulati really quoted a patient and suggested a patient with 3000 ferritin. Do we still really go ahead with the IV iron, or should we really accept the hemoglobin, say at 8.5 and still having a stable, good quality life? Why do we really need to really put that patient in the danger of having more drug-related morbidities and drug-related side effects than to adjust it at around 8.5 or say 8 hemoglobin level? That is one point I really wanted to really know more about it. And the other point is one other aspect. Many of our patients, not many, but few of the patients who are hyper-responsive doesn't seems to be really putting an adequate hemoglobin in spite of the optimized therapy. I've seen that sometimes the LDH is higher. So the hemolytic anemias are also really sometimes play some role into the non-responsiveness or hyper-responsiveness of our therapies. Sir, and on the first thing, so should we really accept the hemoglobin levels at a lower level and avoid having effects, secondary or drug effects of higher iron or higher erythropoietin? And or what do we do?
I am not a recommender. Nobody recommends that ferritin level more than 800 if it is there, that you keep giving iron. Nobody recommends. It's not a recommendation. That we generally go like the pivotal trial went. Even if it is 700, that they have tried to give iron up to 800. It has benefit. Over 800, certainly, there is no recommendation of giving any iron.
Balance between the acceptable
Logically, you will, by and large, you will come across a cause. If you are investigating a person and his hemoglobin is not rising, either we say there is an inflammation lying or there is some deficiency of other factor. By and large, I think maybe a minority of patient, you get frustrated, whatever you do, you can't do it. But most of the time, you will find a cause. What do you say?
Yeah, that's why you are looking for unmet need. That's the unmet need, that many of our patients, you're not able to reach the hemoglobin of 10 and 11. So that's an unmet need. So that's why you are looking for newer molecules which can give you with iron and the current therapy of EPO, you're not able to achieve the hemoglobin. So you are looking for newer molecules. Are they going to be better or not? I don't know yet, but we are looking for these new molecules with the hope that they will be better than that. So anything else?
Sir, if you talk about this patient, he is in a state of inflammation. There might be possibility he might be having underlying chronic infections also. Would you like to would you like to give him IV iron, or there is any role of oral iron here?
I don't know that how you.
You know, I would think that we would look for all causes of inflammation. So if there is an infection, then I would look for infection. It's only that you do not find that there is any infection, then obviously you would want to give intravenous iron. Oral iron, unfortunately, is poorly absorbed in patients of chronic kidney disease, and the reasons are well known, described. Sanjeev talked about hepcidin and all that, and therefore that's the problem with oral iron. Otherwise, oral iron, obviously, it has got GI toxicity, but intravenous iron provides you that. You have to be careful that intravenous iron has toxicity also, and that is infection aggravation is one of the concerns which you raised, and that's the reason. But you would do your best to find out a specific reason for infection. If there isn't, then intravenous iron would be the choice, especially in patients on dialysis. Even in non-dialysis population, if you're not seeing a response with oral iron, or oral iron is not well tolerated, then I would use intravenous irons, even in non-dialysis population as well. Anything else?
Nothing else. Both the panelists have.
So the trials.
Yes.
Sir, I think we can conclude. One thing is sure that anemia is very common in our patient, and we require to give the treatment. No doubt, IV iron is required. Once serum ferritin is more than 800, probably you will not get any more benefit by giving more IV iron. You may get more rather side effects of these things. Erythropoietin is still safe agent to increase your hemoglobin. Choose others for oral patient very cautiously. Till to date, oral agents, if you feel patient is comfortable, keep continue. Should not be considered as if IV is there, oral cannot be given.
So the trials with HIF inhibitors have also shown that by the use of HIF inhibitors, because of the decrease in hepcidin, the enteral iron absorption is increased. So the oral iron preparations become more effective.
Basically, the down regulation of the hepcidin as well as improved response to the EPO and iron utilization.
Yeah, although I must say that at the moment, the trials which have been done, at least I know more about the daprodustat trial because that's where I was involved. And the daprodustat trial, if you look at the iron, need for iron in patients who are on daprodustat and EPO or darbepoetin, the intravenous use of iron was similar. It wasn't any different between daprodustat group. And so at the moment, we don't have evidence that it has improved iron utilization, but theoretically, yes. But what has been shown is that at least with roxadustat, that is the data which is available, that in patients who had CRP levels which were higher and CRP levels which were lower, roxadustat was equally effective in patients who had evidence of inflammation as measured by interleukin-6 and by high sensitivity CRP levels. So they demonstrated that this was equally effective. So which is not so in with the erythropoietin. I think any questions? Yes, Tarun has always a question. Yes.
One question as an experience
Comment. Yes.
Since I was also involved in the Denervation trial, one of my dialysis patients developed tuberculosis. So while I had used rifampicin,
tuberculosis.
Yeah. So rifampicin cannot be used because there was a drug interaction with this because of the HIF inhibitor inhibits the cytochrome P450 enzyme. So for that patient, I had to procure rifabutin after talking to people because it was not easily available. So that patient was managed with rifabutin since rifampicin cannot be used once you're giving this drug.
Yeah, drug interactions. I think that's very important. Drug interactions with the HIF inhibitors with individual drugs will vary, and that might have to be taken into consideration. And that's an important thing which will come. I think the guidelines will give you that these are the kind of interactions which need to be important. Point.
Another issue is that pulmonary hypertension, because this was when we were doing the trial, we had to continuously monitor for that, the development of pulmonary hypertension.
Anyone else? Any comment? Yes.
Sir, sir, do we have any study or any comparative data between the use of ferric carboxymaltose and iron isomaltose?
Iron isomaltose and carboxymalt.
I am not aware of any published data which is comparing carboxymaltose vis-a-vis isosorbide. Most of the people are using carboxymaltose. Yeah.
Yeah, but I think isomaltose has also become available, and basically is the free iron that is released by these molecules is much low, and the free iron is the one which causes toxicity and the adverse effects related to iron, and that's what is probably released much less with these. These are much more stable iron preparations. They remain like this, given slowly over 1 hour. These are considered to be safe. All of us use them in the outpatient basis in our hospitals, and therefore these are considered to be safe irons. And I'm sure, and I must say that iron isomaltose is also being now newly launched by Microfer as well as Ferrizome IV. So that's going to be available now, so you can look at it.
Yeah, I think.
Will you recommend HIF inhibitors as the first line drug over EPU? Partially answered already. Also, one more point I wanted to make for patients on dialysis: if you use high quality water, twice weekly dialysis instead of twice, and you have an AVF instead of a permacath, which causes more inflammation, the EPO requirement comes dramatically down.
There's no doubt. No.
Yeah, I think what you're saying is pearls of nephrology. Good dialysis becomes an important element for hypo-responsiveness to. If you are not providing dialysis, then obviously there is not going to be response to either erythropoietin or to iron. Last comment. I think we need to stop.
So one question to the company people: whenever we give iron, we give 1 gram. That is the recommendation. But all the products available only is 500 milligrams.
I know.
Excepting probably one odd brand. So I think you should look into
because most of people are going up to 1 gram now, and possibly one will have to make it 1 gram vial also. Most of us are buying 500 milligram 2 vials, and then it works out a little more expensive. And most of us have given 1 gram very safely, not once, hundreds and thousands of times we have all given, multiple times.
Yeah, I think we should stop. Thank you. Good things have to come to end, I think. So
one last
we need
question.
to thank you very much for the panelists, and I think we've had a useful discussion. So I will now hand over to Ashwini and to Dr. Tripathi. Dr. Tripathi, where are you?
Thank you, Verma sir.
Dr. Tripathi, thank you very much.
Sanjeev Gulati sir and Microlabs for such a wonderful platform for discussing an important topic.
Yeah, good evening, everybody. We now
we now come to the third phase of our session. And here we have 6 very interesting cases presented by some very brilliant nephrologists here. I would recommend that you all keep your eyes and ears open, because otherwise, if you miss the fine print, the diagnosis will elude you completely. The first speaker is Dr. Geet Vajpayee. He is the senior consultant and HOD at the Venkateshwara Hospital, New Delhi. I thank the board directors and team microlabs for giving
She was a known case of hypothyroidism for last 5 years, and she presented with complaints of generalized weakness, decrease in urine output, and cola-colored urine. She had a history of fever and sore throat, which happened 7 days back, from which she recovered, but gradually developed these complaints. There was no history of any shortness of breath, hemoptysis, oral ulcers, rash, joint pains, any history of NSAID intake, and any history of renal calculus disease. Also, there was no history of any similar complaints in the past. For these complaints of generalized weakness, decrease in output, and cola-colored urine, she was admitted on 7th of February 2022. On examination, the clinical examination was fairly unremarkable, except that she had mild pallor, edema was there over the ankles, blood pressure was 140/80, and pulse rate was 102. Otherwise, the system examination was unremarkable. So the investigations at presentation in the casualty itself, the RAC was positive. The RT-PCR which was sent subsequently came out to be positive with a CT value of 28. The CRP, D-dimer, ferritin were mildly raised. She had a hemoglobin of 8.4. The creatinine at presentation was 6.61, and urine showed full field RBCs with 1+ protein, and UPCR at presentation showed 960 milligram per gram of creatinine. Ultrasound showed normal size kidneys 9.1 and 9.7 with mildly raised ecotexture and normal cortical differentiation. The CTs, the X-ray chest done showed bilaterally increased bronchovascular marking. The CTs showed the CT severity index of 6/25. The other labs showed viral markers were negative, ANA was negative, NT-GBM by IFA was negative, NT-MPO antibodies, that is PNCA was negative, CNCA was negative, and C3 was borderline low, 87 milligram per deciliter, with the lower limit of normal being 90. So working diagnosis of COVID-19 with rapidly progressive renal failure, most likely RPGN in view of rapidly rising creatinine values and active renal sediment was considered. And she underwent kidney biopsy the next day after admission on 8th of February. So this is a low power view of the biopsy core showing numerous crescents in the glomeruli along with patchy ATN and interstitial inflammation. This is a magnified view of the glomerulus showing circumferential crescent with central necrosis. This is a silver stain again showing the circumferential crescent involved in the glomerulus. This is a past stain showing the same findings. So the overall final report of the kidney biopsy was there were 20 glomeruli, 17 showing segmental to global crescents, and the non-sclerosed glomerular turf showed increased mesangial matrix expansion with minimal mesangial hypercillarity. The tubular interstitium showed patchy interstitial inflammation and mild ATN. The vascular compartment did not show any hyalinosis, vasculitis, or changes of TMA. The IF showed that there was predominantly IgA deposits, 3+ IgA, along with 2+ IgG, IgM, and C3, and C1q was negative in the mesangium. So the diagnosis of crescentric IgAN was considered. The patient was started on methylprednisolone pulse just after doing the biopsy on 8th of February itself. The patient was given 3 doses of methylprednisolone pulse followed by 60 mg Vaccination in the tapering dose. She also had to receive 1 session of hemodialysis because of rising creatinine values. and subsequently she was subjected to 4 sessions of Plex. We started with Plex because we had a fear of giving endoxin just in a recovering COVID patient. So initially we start with Plex to control the aggressive nature of the disease, and subsequently she was started on endoxin pulse as well. The total 6 pulse doses were given. First three doses were given in 2 weeks interval, and the last 3 doses were given over the 3-week interval as per the KIDGO guidelines for management of AAV. So this is the trend of creatinine during the hospital stay. At admission, it was 6.61, then it rose to 7.34. We had to give a dialysis session, and subsequently with the treatment, she started responding and just required 1 session of dialysis, and gradually creatinine came down to 2.62 at the time of discharge. During the follow-up also, while she was still receiving the endoxin pulses 2 weekly and then subsequently 3 weekly, the creatinine came down to 1.3, the lowest value, and during the last follow-up, the creatinine was 1.5. So now we come to the discussion part.
Okay.
So this is a study over the COVID infection involves a kidney in various ways. The hematuria and proteinuria are one of the most common findings, and the global incidence rates of AKI in COVID-19 infection have been reported to be around 20%, and the incidence of renal replacement therapy, the dialysis requiring AKI, is about 2.97%. If we talk about the glomerular involvement in the COVID-19, there can be 2 types of glomerular involvement. Either there can be a flare of a primary glomerular disease, which includes flare of IgA nephropathy, steroid-dependent nephrotic syndrome, and anti-GBM disease. And then you can have development of de novo glomerulonephritis that include IgA nephropathy, anti-GBM disease, collapsing glomerulopathy, immune complex glomerulonephritis, TMA, and crescentic GN. All these cases have been, there have been numerous case reports about all these cases. So this was a study which showed that during the literature search, they found that there were 13 cases of IgA nephropathy and IgA vasculitis during COVID and subsequent to COVID-19 infection, and 4 of these IgA nephropathy cases were following COVID-19 vaccination. So in symptomatic cases, they did a skin or renal biopsy, and the immunofluorescence findings confirmed the diagnosis of IgAN or IgAV. Most patients were treated with the steroids and reported recovery or improvement. That was also reported in 2 of the patients. This was another study, the most recent one by Dr. Vivekanand. They presented, they had 2 cases of crescentic IgA nephropathy. Both the patients had severe presentation and required dialysis at presentation. Patients were treated with pulse cyclophosphamide and steroids, but none of the patients recovered kidney function, and they remained dialysis dependent. Now we talk about the crescentic IgA nephropathy in general. So it is defined as more than 50% crescentic glomeruli on kidney biopsy and is seen in less than 5% of all the cases of IgA nephropathy. It portends a poor prognosis. So in this study, they had 43 cases, and all these cases were treated with pulse methylprednisolone and cyclophosphamide, but the kidney survival rate in the 1st, 3rd, and 5th year were about 64%, 57%, and 27% respectively. So even with aggressive therapy, it portends a bad prognosis. So this was a study of plasma exchange as an adjuvant therapy for crescentic IgA nephropathy. So 12 patients with crescentic IgAN were recruited and received plasma exchange plus immunosuppression and were followed for 6 months. And they were compared with 12 historical controls. So 6 of the 12 patients in the plasma exchange group were free of dialysis, while all the control patients were dialysis dependent. So considering all these data in our patient, we started with early and aggressive treatment. We included plasma exchange in the therapy along with pulse cyclophosphamide and steroids, and we had a remarkable outcome, a good renal recovery. So to conclude, COVID-19 affects kidney in various ways. Proteinuria and hematuria were the most common findings, and AKI occurred in about 20 to 29% of cases. So relapse of primary glomerular disease and a range of de novo glomerulonephritis have been reported with COVID-19. Crescentic IgAN is a very uncommonly reported outcome, and early and aggressive treatment with pulse steroids, cyclophosphamide, and maybe plasma exchange can change the outcome.
Thank you.
Thank you.
Dr. Mead. Now, here we had a case of crescentic glomerulonephritis, IgA nephropathy with incidental COVID. Now, the cause and effect relationship, you see, we can still not prove, as was discussed earlier in the evening today, because you see, we cannot show the antigen there,
yes,
or whether treatment of COVID is recovering the disease.
So I still don't know the answer for that, but nice presentation.
Thank you, sir. Thank you, sir. So,
Comments from the house, please.
during my literature search, I looked for the numerous case reports. In many of these studies, they have also done electron microscopy. And in some of them, they have demonstrated the virus particles in the mesangium and the, so maybe that can be the positive. Yes. The causative nature.
What was initially considered to be the viral virions, later was disputed about the artifacts and not very well. So at the moment, there is a confusion about whether this is a direct or the main prevention.
Yes.
COVID virus or vaccination.
Yes. Thank you, sir. Thank you.
Thank you, Dr. Deep.
Thank you.
Now our second speaker is Dr. Tarun Kumar Saha. He is consultant nephrology at the Hyderabad Apollo Hospital. Dr. Saha, please.
Thank you to the micro lab and Professor Verma and Professor Kher. So this is I'll present in about 5 to 6 minutes. This is a case of a post-transplant infection. She is 18 years old girl who was transplanted in the first week of January 2020 with a mother donor. She was inducted with Vaccination with triple immunosuppression, prednisolone, tacrolimus, and MMF. She was discharged with a creatinine of 0.6 with a TAC level of 9.37. Subsequently, TAC level was monitored and it was maintained at around 6 to 7. She was readmitted in the month of December, about 11 months after transplant, with a rise in creatinine of 2.7. That time the TAC level was 5.6, and the kidney biopsy showed evidence of BK virus nephropathy, which is depicted here, that presence of internuclear inclusion bodies in the tubule. Glomerular are largely normal, and there was some amount of interstitial infiltrates. So the same things were shown in the multiple sections of these biopsies, the presence of internuclear inclusion bodies. These girls again developed COVID in the month of May 2021, and after that 3 months of COVID, she developed a rise in creatinine, so we did another biopsy. So second biopsy was suggestive of a type 1A acute cellular rejection. And this is the summarizes, this table summarizes the findings of the kidney biopsy on 2 occasions. First one was having evidence of plus minus stabulitis with a significant presence of internuclear inclusion bodies with SV40 antigen, which was positive in 40% tubules. C40 was negative. IFTA, there was no mention about it. And the second biopsy, there was an evidence of type 1A acute cellular rejection with 60% IFTA. So this table shows the serial monitoring with serum creatinine and the immunosuppression which are given, and the VK virus quantification, quantitative reports. So as you can see that the rise in creatinine continued when she had a VK virus nephropathy because of some other associated issues like GI bleed, and also there was an element of 18 as well. And the viral load was very high. The immunosuppression was reduced. At the time of diagnosis, she was on prednisolone, MMF. At the time of discharge after the first biopsy, she was on prednisolone, MMF. Second biopsy, I'm sorry. When she was detected to have a BK virus nephropathy, actually she was being managed by other people. She came to me in the month of February, and that time we decreased the immunosuppression and we changed it. At the time of diagnosis of BK virus nephropathy, her immunosuppression from TAC was changed to cyclosporine, and my MMF dose was reduced. It was not stopped. When she came to me, she required dialysis, and we found the viral level was high and the dose was cyclosporine was stopped and MMF was also stopped. Prednisolone was marginally increased and she was started on leflunomide, 20 mg. With this, she showed the improvement in creatinine, and subsequently, as you can see, you can see that the viral load has come down gradually over a period of few months, and the immunosuppression, which was on prednisolone 7.5, leflunomide was increased to 40, and she was added with the sirolimus 1 mg. Later on, she developed COVID, so temporarily that time the leflunomide was stopped and prednisolone dose was hiked up. Sirolimus also temporarily reduced, and subsequently after she recovered from the COVID, she was discharged with prednisolone and sirolimus. Leflunomide was not started. After 2 months of discharge, she developed a slight rise in creatinine from 2.1 baseline to 2.9, and at that time kidney biopsy showed evidence of acute cellular rejection. She was anti-rejected with 3-methyl prednisolone doses, and she was discharged at the time with prednisolone 10 milligrams, sirolimus 2 mg, and mycophenolate was added at that point of time, thinking that her BK virus quantitative has come to below 1000. So that time it was mycophenolate was restarted. Subsequently, we followed this patient and we found that the BK virus level was undetectable, and she has continued with the immunosuppression of prednisolone 7.5, sirolimus 2, and mycophenolate 360 only per day. Her creatinine was done just 2 days before I came, and it was found to be 2.3. With the same immunosuppression, we have continued, and she's been advised to repeat the BK virus level again when she comes for the next follow-up. So we'll come to the brief discussion if we have 2-3 minutes. So that there were, in the historical aspect, the BK virus was first isolated in 1970 from a kidney transplant recipient with the ureteric stricture. That says that it is common to have a ureteric stricture in severe BK virus nephropathy patients. Up to 90% of human population became exposed to BK virus by adulthood. Okay, fine. No, this case we have. I have discussed the follow-up of this case also till date. That is, yeah.
You have very bold decision to prednisolone and leflunomide. Now, when the person had high copies, you stop cyclosporine or that, you stop MMF, patient would be on prednisolone and leflunomide. Any data?
Yeah, I will tell you the reason, clinical decision, what made me do that. See, this patient was being treated in another hospital where, in spite of BK virus, he was discharged with the prednisolone of 5, MMF of 540, and cyclosporine of 200. At the time of discharge, creatinine was 3.2. But when she came to me with a creatinine of 8, I had no other option but to drastically reduce the immunosuppression to save her from going into the catastrophe due to the BK virus infection. And as you can see, that drastic reduction of immunosuppression has yielded in reduction in creatinine. We had to give her dialysis that time. So after initial reduction of immunosuppression, she did not improve. In fact, her creatinine rose. That made me to take that decision. I know this question may come. So MMF, when you stop MMF, leflunomide is another immunosuppression, which is not only the immunosuppression, it acts, it has some antiviral role in BK virus. So if you give me a few minutes time, I will go to the, I'm removing these slides with lack of time. This shows the proposed.
I think I will just summarize and then we ask some questions.
Right, fine, no problem.
See, the BK virus is a really difficult problem to manage. And you see it relentlessly, the creatinine keeps going up, and the real treatment is to decrease the amount of immunosuppression. We stop the MMF, we come down with the tacrolimus. Leflunomide and this ciprofloxacin group of drugs have been tried and with very doubtful results. Sirolimus and everolimus seem to have some antiviral properties, could be of some help, but they seem to have worked in your case. And now when you have a simultaneous rejection,
I did not use it for that reason. I used it as an immunosuppressor because mycophenolate and CNI are right for.
Another pertinent question: when to re-add mycophenolate?
Suppose somebody is coming with a rejection in the presence of BKV, it's a more difficult problem to manage. And
yeah, that's
because
what
you see the treatments are diametrically opposite.
Yeah.
So some people say IVIG in big doses could help, but it is a very difficult disease to treat. I think
So the case shows that when the BK virus level was not detectable, that time we should start the microphenotype, because that time we know that the virus has gone out because of our whatever interventions we have done. So that time restarting with the smallest possible dose. She is only on now 180 BD of microphenotype, which is very minuscule dose. But this has kept her graft function reasonably well. So if you give me one more minute time, this is only new things which I could come. In my patient, I did it almost every month when she had that episode. But last nearly 10 months, I have not done because she's doing well. If the creatinine is normal, probably not needed at the end of, this is now 2 years of post-transplant. Now, just quickly to highlight one new thing which I come across when I was asked to present this case by Dr. Verma, I even didn't know that this term called the urinary, I don't know how to pronounce it, Haufen level, which is basically a icosidral aggregation of polymyvirus particles, which gets embedded with the TAM hospital protein, and one can see it in electron microscopy. This seems to have a 100% sensitivity and 99% specificity. All other tests are not so much of sensitive or specific because of several reasons which I'm not discussing due to lack of time. And the table has shown the sensitivity and specificity pattern. So now this is the KDIGO recommendation that that after any transplant, irrespective of you have BK virus or not, these are the way you should monitor the monthly blood BK virus level. So monthly plasma screening for first 3 to 6 months post-transplant, this is KDIGO recommendation. Then every 3 months until the end of first year. It is the first 1 year which is the maximum infection rate happens. And American Society of Transplantation recommends monthly plasma screening for the first 9 months and then every 3 months thereafter for the first 2 years. So these are the two recommendations for monitoring BK virus in any patient post-transplant, not that you are suspecting.
Thank you, Dr. Saha. Yeah. We move on to the third case to be presented by Dr. Jha. He is Senior Consultant Nephrology at Care Hospital, Hyderabad.
Good evening, friends.
I should get a Patiala.
I thank the Professor P.P. Verma and Dr. Vijay Kher for giving me an opportunity, and as well as the organizers for asking me to be a part of this CMB symposium. The interesting case that I'm presenting, in my experience of 30 years, this is the only patient where I have seen this a kind of complication which I have been able to manage successfully to the patient's satisfaction. A patient of recurrent life-threatening complication in a post-renal transplant recipient, which we have managed in last 1 year. This is a patient who is 41-year-old male software professional with a native kidney disease, horseshoe kidney, with a presumptive diagnosis of CKD-CIN. His transplant was done about in 2011 when it was about 10 years back from an HLA unmatched donor, and the follow-up subsequent to that was at Bangalore. He was recently located to Hyderabad after lockdown in 2020 because he was the software professional, and Hyderabad being a hub, he chose to be relocated to Hyderabad. His history showed that he had received Bacilliximab as an induction agent in 2011 for his HLA mismatch transplant, and he had developed post-transplant diabetes 2 years subsequent to that. And he was on triple drug immunosuppression containing deflazacort, MMF, and tacrolimus when he presented to us. He presented to us with history of worsening pain and swelling of the left leg of sudden onset with no preceding history of trauma, fever, discoloration. Clinical examinations showed that he had a left leg which was swollen and tense compared to right. His vitals were normal. He was having a BMI of 25. And with a clinical diagnosis of DVT, the venous Doppler of the left lung confirmed it as a DVT, which was extensive, involving the left external iliac vein, common femoral vein, popliteal vein and tibial vein thrombosis was also documented. What we see in the Doppler is self-explanatory. On the right side of the screen, what we see is that both the arteries and veins are showing a Doppler signal, while on the left side, what we see clearly is the vein is showing a kind of no signal, suggesting that the patient is having a thrombosis in the left common femoral vein. When we inquired his past history, there was significant past history of acute intense hemicranial headache about a year back before he presented to us with vomiting. Evaluation suggested at that point of time in Bangalore that he was having acute left transverse sinus thrombosis, for which he received warfarin therapy for 8 months. And he stopped it subsequently for last 4 months because of lockdown, because he thought that is not required. The image that is shown, it is showing that CT scan of the brain is showing a kind of left transverse sinus thrombosis, both in the left as well as the right side of the image. We see clearly the thrombotic vessels with clot. The MR venogram of the brain showed clearly the confirmed diagnosis of left transverse vein thrombosis. So this patient had a thrombophilia evaluation in Bangalore, which was found to be negative. Patient was having no evidence of coagulopathy based on factor V Leiden mutation, antithrombin 3 level measurement, protein C, protein S, fibrinogen level, and APLA, which were all normal. He had, however, a homocysteine level which was quite high. It was 65, and the basic cutoff was 50. His labs at this time when he visited to me was a hemoglobin of 14.9 with a creatinine of 1.4, which are risen to 1.7. Other parameters, including hemoglobin A1C, was normal. He was getting tacrolimus, MMF, deflazacort, linagliptin, Novomix, metoprolol, prazosin, and cilnidipine as a part of his comorbidities. The further tests which were done showed the D-dimer level quite high. COVID screening was done as a part of workup because patient had come at the COVID time, which was negative. HRCT chest was normal, so also the 2D echo. The genetic testing for the TAC metabolism was done because his TAC levels were found to be quite high, and it was reported as normal bioavailability phenotype, that is, he was not a slow metabolizer. The course in the hospital, patient was given enoxaparin to begin with twice a day, 40 milligram for 5 days, IV hydration, and it was followed up by a novel anticoagulant, apixaban 5 milligram twice daily. Serum tacrolimus dose was reduced gradually from 2.5 milligram, which he was taking for last 10 years, BD dose, to 1 milligram BD over time, and his tacrolimus level dropped from 16.2 nanogram at the time of presentation to 5 nanogram per ml in the follow-up. So this is the slide which shows that how the serum creatinine rose and came down from 1.4 to 1.7 to 1.6 to 1.4 in the last follow-up and 1.3 now. His repeat Doppler, venous Doppler at 3 months showed complete recanalization of the venous system. So the interesting point that I wanted to highlight in this patient was that he was having an acquired hypercoagulable state in a renal transplant situation. The late onset unusual thrombosis was quite interesting. The recurrence of thrombosis happening because of drug discontinuation. The risk factors for this patient, which we thought could be playing a role, is the very high dose of CNI, presence of diabetes, hyperhomocystinemia, and his habit of sitting because of his software professional. There are no past history of DVT, neither he had femoral catheterization. The duration of anticoagulation, what to give, how long to give, was a point in the beginning, but it's now clear that he had a recurrence of this thrombotic event, and hence he requires a lifelong therapy. And the choice of anticoagulant, particularly the novel anticoagulant, which has not been used to that extent in the post-transplant, was an interesting point. The reasons for the post-renal transplant hypercoagulable state is shown in the slide. The various factors have been reported in literature. Immunosuppressive drugs like CNI and steroid have been blamed. Antiphospholipid antibodies and lupus nephritis as a part of hypercoagulable state has been reported. Hyperhomocystinemia is also reported to be an important factor which may be contributing. Pre-transplant dialysis modality, particularly PD, has been said to be associated with high risk of thrombotic events. Post-transplant erythrocytosis, recurrence of nephrotic proteinuria, and acute CMV are the other factors which have been associated with increased hypercoagulable state. So whenever we are prescribing the drug, the novel oral anticoagulant, in association with CNI, there are certain things which we need to remember that the CNI, particularly the cyclosporine, is a potent inhibitor compared to the tacrolimus of the PGP transport protein, which can lead to a rise of 20 to 25% of the plasma levels of NOAC. But it has been said that if you are trying to reduce NOAC because of this interaction, the risk of thrombosis doesn't get abated, neither there's a risk of increased bleeding if you are not modifying the dose. The CYP450 inhibitors particularly have to be reduced by 50% for all NOACs except dabigatran when they are co-administered with CYP450 drugs. Despite the risk of CNI or NOAC levels, there is not much risk associated with tacrolimus-based therapies as was seen in this patient if the dose is modified based on the GFR. 1 year later to this thrombotic event, when he was on apixaban, he developed COVID infection with severity of 8/25. He was having a kind of persistent fever for which he was hospitalized, though his oxygen saturation was normal. He had a rise in creatinine from 1.4 to 1.7. His biomarkers were not very, very abnormal. D-dimers, ferritin were reasonably all right. IL-6 was high. He received IV methylprednisolone in a dose of 40 mg BD, remdesivir, vitamin C, vitamin D, and antibiotic tazobactam, and MMA was stopped. These are the images to show that he had a bilateral classical CORAD 5 feature with a score of 8/25. In the follow-up, luckily for the patient, he didn't develop any thrombotic complication post this COVID infection, because which is a known kind of risk which is reported. It was possibly because of the continuation of apixaban because of his previous thrombotic events. He had a complete recovery. He is doing well post COVID 1 year. His latest creatinine 1.3, though he had proteinuria 1.4 protein to creatinine ratio. Hemoglobin is still good. Hemoglobin 15, hemoglobin C 8, and he has received Covaxin 2 doses without any kind of detrimental effect. So to summarize, the interesting point in this patient is that he had a thrombotic complication in a post-transplant setting, which is a real challenge, which has happened about 10 years post-transplant. If neglected, thrombosis not only can compromise the graft function, but it can take care of even the life. Drug interactions is a real concern while managing this patient, and when you're using NOAC, we need to understand how the drug interacts. NOACs are definitely a better choice compared to the older generation drug because of the good safety profile and no need of monitoring, as was seen in this patient. And the use of NOAC probably prevented the thrombotic complication of post-COVID that we are always afraid of. Thank you.
Thank you, Doctor. You see, you have worked up the thrombotic tendency in big details, and we didn't come to any big conclusion. The only surprise for me is that during the episode of COVID, when the tendency of thrombosis is the highest, the patient escaped without thrombosis. Only factor I can think, you see, though it is not a very strong point, his hemoglobin was 15 around like that. Maybe that contributed a little bit, though it is a little too low to ask for bloodletting or anything like that. Maybe some aspirin could have made a difference, but I don't know.
One of the very important study published in Kidney International in 2014, which is a very large study from Canada, has looked at the risk factors, and they have said that anemia is a risk factor rather than the thrombocytosis. That is our presumption, but it was not found to be the case. It was found that drugs like sirolimus is a drug factor which is implicated in a risk of thrombosis. And even there are few more other risk factors have been mentioned, but not erythrocytosis, which was noted to be there, etc.
Not committing to this.
So these factors could be many. It is very difficult to be sure about one about the others. But this patient didn't have the recurrence of thrombosis probably because apixaban was continued during that point of time.
Thank you, Doctor.
Thank you.
Now I invite Dr. Kanda Swami from Coimbatore. He is a senior consultant in KMCH Hospital, Coimbatore.
Good evening, one and all. This is a long, sad story of a patient with nephrotic syndrome. He is 21 years. He had a biopsy-proven FSGS in 2018, treated at Pondicherry with steroid, and he was branded as steroid resistant. Subsequently, he had cyclosporine along with steroid from a hospital in Chennai for a period of 2.5 months. It has to be stopped because he had a rising creatinine and there was no response to therapy. However, there was no improvement in the renal function following withdrawal of CNI, and he had a second biopsy which showed 70% IFTA. So he presented to me in December 2019 with tense ascites and difficulty to walk. So going back his records, he had 3 hospitalizations between April 2019 to December 2019, one for ESBL UTI and another for abdominal wall cellulitis, and lastly he had a severe bad cellulitis of the leg also. When I saw him, he was emaciated. His power in the lower limb was 2/5. He has tense ascites, bilateral pleural effusions. His creatinine was 1.9. His serum albumin was 1.6 grams. He had a heavy proteinuria and suppressed cortisol and elevated TSH and low vitamin D level also. Because he had a lower limb weakness, we did a CPK, which was normal, and EMG showed a myopathic pattern. He was started on a physiological replacement dose of hydrocortisone and small dose of thyroxine. He was subjected for a 6-liter paracentesis, and it was a translate. So is it a primary FSGS or mutational FSGS? Because he was not resistant to steroid and cyclosporine. And I felt it is not a good idea to restart CNI or rituximab because it was an advanced disease with 70% IFTA. And it was almost certain that it is very difficult to manage this patient conservatively because he is severely malnourished, having tense ascites, bilateral hydrothorax. He had a hypothyroidism, vitamin D deficiency due to massive proteinuria. And he had 3 life-threatening infections in the previous 6 months. And he had a very low serum albumin warranting anticoagulant therapy also. So at this point, I sent a genetic analysis, and I was convinced in my mind that it's very difficult to proceed, manage conservatively. And an option about bilateral nephrectomy was given to the patient relatives and the patients, and an option on bilateral renal artery embolization also given. And his cousin is a research fellow in USA, want a detailed summary, and they have decided to choose bilateral nephrectomy. So this is a patient, you could see wasted arms, and this is pictures after paracentesis. Even the abdomen is tense, and he was subjected for bilateral nephrectomy post-op because of the severe hypoalbuminemia and adrenal suppression. He had a recurrent hypotension, which was managed with pre-dialysis metodrine and albumin. Vitamin D replacement was continued. After nephrectomy, thyroxine replacement was not there. It was stopped after a few weeks. And within 3 weeks, he was able to stand with and walk with support. By 2 months, he was able to walk off his own. But the dilated cardiomyopathy persisted even after good dialysis and bilateral nephrectomy. So a gene analysis was done by clinical exam study was done, which showed a LAMP2 mutation, which was autosomal recessive heterozygous. But it was reported as a variant of uncertain significance. And at this point, we are not very sure whether it is really the mutational which is contributing to the nephrotic state, or it's just a primary FSGS which is resistant to all the immunosuppressive drugs. And an option about renal transplant was given. Mother was a diabetic, so father was incompatible blood group. Patient group was A and father's group was A. Patient's group was O and father's group was A. And the COVID lockdown begins. So next 1 year, we could not consider him for a transplant. His father was worked up, and we got a committee approval in November 2020. Unfortunately, as we were planning for a desensitization protocol, he had a loss of appetite, nausea, fatigue, found to have hepatitis C positive. And we know that spontaneous clearance of acute hepatitis C is about 20 to 50% over 6 months. So now the current recommendation is not to wait for a spontaneous resolution, and with the availability of directly acting antiviral drugs, the recommendation is 1B. So in these patients, pan-genotypic regimen of sofosbuvir, velpatasvir was started, and within a month therapy, his RNA was undetectable and liver enzymes was normalized, and we have decided to continue for 3 months. So after 1 month of antiviral therapy, we started the desensitization protocol for the ABU incompatible transplant. He was given 200 milligram of rituximab, and MMF tag was started day -14. 8 sessions of plasmapheresis is required to bring down the titer to 1:16, but last 4 sessions to bring it from 1:32 to 1:16. He was given Similac induction, and IVIG was given 0.5 grams per kg. And because he is anaphoric, anuric for 1 year, a double J stenting also kept during the time of transplant, and immediate post-transplant was uneventful. By 6th post-operative day, he was with nephrotic proteinuria, and there were plenty of RBCs in the urine. And his immediate post-op anti-A titer was 1:8, and by 9th day it was 1:16. At this point, I was not too sure whether it is whether an ABMR or a recurrence of IgN, FSGS. So he was taken for 1 session of plasmapheresis, and a renal transplant biopsy was next day done, and it showed no rejections, no pyelonephritis, and there was a vascular tubulopathy, and there was C3C deposits without any endocapillary or mesangial proliferations, and he had some donor-related changes also in the biopsy. Since there were C3 deposits, we did a complement C3 level, which was low, and I was not too sure whether it is an effect of plasmapheresis. And there was incremental proteinuria to the tune of 3.5 grams per day. So repeat biopsy was done to do an electron microscopy on the 12th day. He also had a type 4 RTA, difficult to manage hyperkalemia, requiring soda bicarb, thiazide, and K binders. So he was not able to, I am not able to start ACE inhibitors or ARB immediately. And he had also postprandial hyperglycemia requiring OHA. So electron microscopy came as a diffuse effacement of the visual epithelial process. There were no electron dense deposits in the mesangium, whereas in light microscopy there were C3 deposits, and there were some electron lucent vascular inclusions in the cytoplasm of the tubules, but no viral particles. Since it's a clear-cut FSGS, another 3 sessions of plasmapheresis was given alternate days, and then there was a progressive reduction in the proteinuria, and serum creatinine also stabilized around 0.9. We had also had difficulty in achieving a desired TAC level, so I had to put him on diltiazem and ketoconazole. So this is electron microscopy showing the diffuse food process effacement. And is it a genetic mutation with recurrence or primary FSGS with recurrence? His mutation is LAM2 mutations. The anti-laminin antibodies are not described in post-transplant situations. It is described only in preeclampsia. The common cause is a primary FSGS related to low molecular weight anionic glomerular permeable factors, which is likely in this case. So not to forget, there are reports of directly acting antiviral drugs causing FSGS and proteinuria in liver transplant settings without any viral cytopathic effect on the kidneys. So since these patients had received a directly antiviral therapy, that also was kept in mind. So he had a severe hyperkalemia requiring at least 15 to 30 grams of binder and soda bicarb 6 grams per day, hydrochlorothiazides. An attempt to stop cotrimoxazole did not help. And with all these binders and thiazides, irbesartan was started 75 milligram as an antiproteinuric. He initially tolerated, but when I increased the dose, he had a promptly hyperkalemia. So it has to be stopped, and fludrocortisone was added. So for the first 45 days, his creatinine was stable around 0.8 to 0.9. His albumin was around 3.5 grams, and proteinuria was about around 3 grams. With this thing, ARB could not be continued, and further plasmapheresis escalation like rituximab was not initially considered. And on 45th day, he had a right infrascapular pain, pleuritic type, and his COVID was negative, saturation was normal. At this point, he was not on very big dose. 45 days, prednisolone 2.5 is very minimal dose. TAC level was not very high. MMF was okay. So cultures were sent, and he was started on moxifloxacin. And this is the X-ray not showing any infiltrates. And the pleuritic pain and fever continued. So I decided to take a CT of the chest. You could see the right lesion abutting the right pleura. And this is a venous face. And this is a sagittal section of the venous face. And when I retrospectively went through the X-ray and made it darker, you could see the lesions behind the diaphragm, which I have missed. And a CT-guided biopsy was done in the next day itself, which showed aseptate hyphae, suggestive of mucormycosis. He was taken for a segmental resections, and he was started on a low dose because surgically we completely removed it. He was not started on 6 milligram per kg. He was started on 3.5 milligram per kg of liposomal amphotericin. ICD was removed, and with amphotericin from hyperkalemia, he became hypokalemic. I had to stop all the drugs, and he was requiring 100 millikelens of potassium replacement every day, and his magnesium was normal. MMF was stopped for a week and then restarted with 50% dose. This is infarcted lung, you could see, and mucor invading the vessels. And these are the classical mucor aseptate hyphae, which was demonstrated. With 12 days of liposomal amphotericin, creatinine increased from 0.8 to 1.4 milligram per deciliter. So it has to be changed to isavuconazole, which was continued on the prescribed dose. And since it is a cytochrome P450 inhibitors, it is mandated to stop the other inhibitors. And this case, he was on diltiazem ketoconazoles, which was stopped. And this is a mild to moderate inhibitors. So proactively, I increased the dose of TAC a bit, and then the levels were monitored. And it is mandated to monitor the ECG because it can cause short QT and arrhythmias. And ECG was normal. This is the 10th postoperative pictures. 16th day and 3 weeks, almost a total clearance of the thing in the CT. And it not get over. And 75th day, he developed COVID infections, and which was a mild thing. And dose of TAC was reduced, and MMF was stopped for 5 days. So totally, he had 12 days of liposomal amphotericin, isavuconazole for 3 weeks, posaconazole for 3 weeks, and he completed antifungal therapy. And towards the completion of antifungal therapy, he has a rise in creatinine subjected for a biopsy, which showed a evolved FSGS with CNI toxicity. Dose of TAC was reduced, but didn't help. The creatinine remained around 2, and there was incremental proteinuria. So I have no options other than to give a dose of rituximab now. 500 milligram was given, and within 10 days, there was a further rise in creatinine. So a repeat biopsy was done, which showed interstitial inflammation with eosinophilic infiltrates and interstitial edema. At that point, he was only on thiazide, which is likely to produce acute interstitial nephritis, which was stopped. After stopping also, there was a further rise in creatinine. So after discussing the family, 3 doses of pulse steroid was given. And after pulse MP also, there was a mild increase in creatinine. So we wanted to rule out a BK virus, and urine decoysal was negative, and BK virus qualitative PCR in the blood was negative. A month after giving a pulse mesalprednisolone, he developed a left-sided pleuritic chest pain this time, and the creatinine was around 3. And CT showed a left round pneumonia. He was empirically started on meropenem, posaconazole, linezolid, and he also had neutropenia and started on GCSF. And he was subjected again for a CT-guided biopsy and ball, which was negative for everything except a ball fluid group, Klebsiella. And so the other linezolid, posaconazole were stopped, meropenem was continued. And towards 2 weeks, end of the therapy, he developed a same-side moderate pleural effusions, and subsequently pericardial rub with the pericardial effusions. So even though the Nocardia was negative, I was strongly suspecting, so minocycline was added, and he required intracostal drainage, and the minocycline was continued. So at this point, this infection, we decided to withdraw the immunosuppression totally. MMF was stopped once for all. Tacrolimus was planned to wean slowly to avoid graft intolerance, and it was slowly tapered and stopped over 6 weeks. And minocycline was continued for 3 months, and he became dialysis dependent by mid-September 2021. And now he's nutritionally preserved with good albumin and hemoglobin. And this is the lesions on the left lung this time. And this is a moderate effusion which he developed on treatment with meropenem. And this is with a pictile catheter. And this is after removal of the ICD. And this is 6 weeks of minocycline. So what predisposed him to multiple infection? Undoubtedly, the number of plasmapheresis, the hypoalbuminemia he had, the acute hepatitis C infection he had, and recurrent FSGS.
Thank you, Dr. Saha. You see, the important point in this case, in this very eventful cases, that this patient had FSGS. You see, I appreciate the decision that you took to remove the kidneys, because when you're losing such high amount of protein, you could see on the picture the amount of emaciation that this patient had, and that made him good enough.
Yes.
But I don't appreciate the decision to go for a second transplant, because when you have a recurrent
it's a first transplant. It's a first transplant. It's not it's a first transplant.
Okay.
The first transplant, he had a recurrence of the FSGS.
Okay. You can continue.
Very exhaustively and nicely managed. Any comments on the floor?
So the complications are because of, you see, over immunosuppression and continuing immunosuppression. You see, if you look at his emaciation, his creatinine of even 1.8 was equivalent to 4 or something. And we should have given up the kidney much earlier, actually. In fact, if he had given up the transplanted kidney, maybe he would have escaped all this trouble. Thank you.
Any comments? Thank you.
Any comments? Thank you.
You did a fine job.
Thank you.
Very well managed.
Thank you.
I call upon Dr. Sanjay from Saptagiri Hospital, Bengaluru.
Because I think from the reaction of the audience, it appears that we are now losing interest. Fair enough, fair enough.
So thank you, Microlabs. Thank you, Goel sir and Tripathi sir. So, when we say present interesting cases, we are always happy to present where we had been successful. I took up this case because it gives us some insights. So this is a 43-year-old male patient presumed to have interstitial nephritis with on dialysis of 2.5 years. HCV positive on treatment for 2 years, and HCV RNA had become negative. Patient had problems with his access. It was a severe problem, and it was so difficult to maintain him on dialysis. And he was getting into protein energy wasting. He underwent a live-related renal transplant in November 2020. Donor was father. We took up an old age donor because, as I told you, he was not doing well on dialysis. And I am into old age donor transplants. So the DTP-GFR of the father was 88 ml when we checked it. So induction was done with Graflon 100. It's a haplomatch. I tend to keep the immunosuppression down because, as you know, it's an old kidney. So I don't want the TAC-related complications to happen in the old kidney. He was on TIP-12 immunosuppression with TAC, MMF, and steroids. Steroid dose, again, not very high. I reach almost the dose of 7.5 milligrams, which I maintain within 8 weeks. And TAC level, I start minus day 5 because on the day of the transplant, I know what my TAC levels are. So on the day of the transplant, it was around 8.2, acceptable range. So Restol was almost normal. So his creatinine was coming down, but it was not, had not reached the normal on the 7th day of his discharge. He was on Vicelon 20, TAC 6 milligrams per day, mycophenolate 1 gram per day, and rest of the drugs. He came after 15 days with history of fever of 1 day, which was intermittent, high grade, no systemic symptoms at all. When we recorded the temperature, it was 100, BP stable, Counts were little low, 3,100. And we had done culture and all the tests as required. So TAC level at that time was 9.1. CMV PCR was negative. You started on broad spectrum antibiotics. All the cultures were negative because the counts were low. GM-CSF was started. Gansack level was stopped. Bacterium DS was stopped. He received hydration as he was dehydrated, and TAC dose was reduced because I tried to maintain between 5 to 8. And on one thing about the patient was he was little irregular on the follow-up. He maintained creatinine of, which was recovering at the time of discharge, around 1.5. He maintained the same. There was no significant improvement. I also thought there is a possibility it might take some more time because it's an old age kidney. And he did not agree for a graft biopsy. And when I asked him all the signs, there were no signs which were consistent with rejection. And the creatinine always maintained in the same range. TAC level again maintained between 5 to 6. He never looked classic post-transplant healthy patient. You know, you see the glow in the patient after a few weeks of transplant. He was not doing that great. No weight gain was seen and he looked unwell. Creat was again 1.5 to 1.7. Dehydrated, decreased intake, multiple tests for evaluation to see very hidden infection. He included all kinds of CT chest, ultrasound abdomen, CT abdomen, everything was done. Cultures were done repeatedly, which was not showing us anything. And he had no others, except for being unwell. There was no other signs saying that he had infection anywhere. Now, this went on for 6 months. And he presented to me one day with creat of 2.6. I didn't saying that I found the creatinine to be high. TAC level at that time was 6.2. He was adequately hydrated. Dose of the tractolimus, again, I reduced it at that point of the time. Graft biopsy, this time he agreed. And in the graft biopsy, as you can see, normal glomeruli, it was more of a ATN, which was showing no CAS, vacuolation, inclusions, vessels were normal, IF was negative, C4D negative, and there was some evidence of acute tubular injury. And as I told you, he was dehydrated, he was hydrated at that point of time. Creatinine after 1 week returned back to 1.5, the baseline what he had. He was stable with no complaints. Again, after 1 month, he consulted me once more for only 1 day of fever. All tests were normal. Prophylactic antibodies we gave, antibiotics we gave, and mycophenolate I reduced to 750 per day. He was lost to follow, just sending reports on the phone of his creatinine. 8 months post-transplant, he presented with a history of intermittent fever for 1 month duration, has been having this fever intermittently for a week, and was taking antibiotic courses on his own. He looked toxic. BP was 160/90, heart rate was high, respiratory rate was maintained well, systemic examination normal except mild edema. Patient had been admitted for evaluation, and these were the tests. All were recorded to be normal, except that his creat was 2.1 at that point of time. So because I knew something is happening at this time, I also did the bone marrow biopsy aspiration culture of that. And in the end, because everything came negative, I thought let us do for evaluation of underlying malignancy. So I asked for a PET scan. So PET scan showed a hypermetabolic subcentimetric right supraclavicular mediastinal lymphadenopathy with moderate ascites, which he has developed within a period of 4 days. The first ultrasound was normal, and between the ultrasound and the PET scan, gap was around 4 to 5 days. And all the other tests as shown is negative. He underwent a diagnostic laparoscopy. So diagnostic laparoscopy with peritoneal and omental biopsy was done. Ascitic fluid analysis was done. Then he was on treatment with broad spectrum antibiotic, that is imipenem celastine. Histopathological examination of the biopsy was consistent with a granulomatous lesion. So here we started him on ATT as the dose was as per the recommendation based on the creatinine levels. Now, patient general condition improved with this.
Just 1 minute.
Yeah.
Are you happy giving rifampicin to transplant fellows?
I keep a close watch, sir, because it was, I keep a close watch. And usually the TAC level is monitored when I'm doing it. I use it because it is one of the bactericidal agent. So I use it in transplant. 2 weeks later, he started having low-grade fever again with cough and diffuse mild to moderate pain abdomen. So all this time he was on follow-up with me, and I was a close watch. COVID-19 analysis, multiple times 3 sessions were negative. Again admitted for evaluation. So at that time he had little pallor, edema, tachycardia. Investigation showed that hemoglobin was low, total count has increased, and creat has touched 2.7. Procalcitonin was very high. And when I did the X-ray, there was a cavitatory lesion in the left upper lobe. Now the difference between the previous X-ray to this X-ray is just 1 week. So non-homogeneous opacity was there. Along with that, HRCT showed a large irregular hypodense areas with cavitation and with air-filled levels involving both the right upper and the right lower lobe, sort of lung abscess. As you can see on the left side, there is a large cavitary lesion with surrounding pneumonia there, and it has contents inside. MF was reduced, TAC was brought down, an induced sputum for analysis was done. CT, now they had also done the scopy, but as you know, the lesion was more peripheral. They could not get anything. So immediately, simultaneously, I expected we may not get a major benefit out of it. So CT guided lung biopsy with aspiration of the cavity content was done. And amphotericin B, because commonly we think it is a fungal, already started before I got the report. Imipenicillin was continued, and I had increased the dose of Bactrium DS because thinking it may be atypical because it has happened so fast. Sputum analysis said AFB positive, acid-fast filamentous structure consistent with nocardiosis. So no fungal elements. This is what we found. And in my 25 years of experience as a doctor post-MBS, I had never seen an nocardiosis before. Sputum culture sensitivity showed multi-drug resistant Klebsiella moderate sensitive to colistin. So colistin nebulization was added, RFT stabilized, he started improving. But as the general condition improved, the repeat X-rays which were done showed involvement of the lung on the right side also, to an extent that the whole right lung was eaten up and it was looking like a full bag, empty bag. Now the problem started that he started developing thrombocytopenia, which was very significant over the next 3 days. And it was not responding to any treatment. We have done everything. Steroid dose was done. We did the bone marrow biopsy to find out whether it is the depression of the bone marrow. There was no depression of bone marrow. That means it was getting peripherally utilized. So all the tests related to this, including the antiplatelet antibodies, all were negative. D-dimer was very high. Procalcitonin continued to be high. Patient was stable. RFT got stable, came back to 1.5, 1.6. Antiplatelet antibodies, I said, is negative. Lung biopsy report was consistent with nocardiosis.
What did you do for the nocardia?
I'm telling you that. So nocardia, he was getting high dose of, nocardia is sensitive with the Bactrium DS he was already on. Along with that, imipenicillin is the drug of choice. So that was continued.
And sometimes linezolid, I suppose.
Linezolid was later added, but he was responding. He responded. He came out of oxygen and we wanted to shift him to the ward. But the main thing was his low platelet never responded. He maintained between 8,000 to 16,000 with multiple transfusions. At one time, he thought more of transfusion will cause problem to him. We stopped. And in the end, we lost him because of the IC bleed which happened to the patient. And I think this is one of the negative effects that I have had in the transplant. And
well, thank you. You see, this is a big complication, fungal infection. You see, post-transplant is a really difficult thing to manage. And we may have a big mortality, whatever you may do. Thank you.
Thank you.
Dr. J. Balasubramaniam from Tirunelveli.
Good evening, the chairpersons. Let me thank Dr. Verma, Dr. Vijay, and micro people to have brought me here, and no thanks to making me stand in between the audience and the dinner. So this will be a very short presentation. This is not so much so for the difficulty in diagnosis, but the difficulty it posed to the patient and the physician in charge. Central vein catheters, although we are biased against it, we continue to use it, and it is enticing to use it more. And especially more and more nephrologists putting in tunnel catheters, the central vein catheters numbers are increasing. And we know that it can cause, one of the problems is symptomatic or asymptomatic venous thrombosis and distant embolization, which can cause limb edemas, SVC syndrome, and pulmonary embolism. So I had a recent case, a 32-year-old male who had a tunnel catheter for CKD dialysis of 3 months old. He came with swelling of the face, neck, and upper body of the arms. fullness in the head and ears, difficulty in breathing, especially when bending down. He had cough and hoarseness. And this was his picture. And so it is very obvious that he had features of SVC syndrome. He was sent for CT angio, and it showed thrombus in the brachiocephalic, in the SVC. And during the CT, they also mentioned that he had a opacity in the right atrium. So we went and the echo showed the right atrial thrombus as well. So he had SVC thrombus, SVC syndrome, and catheter-related atrial thrombus. And so he was in double jeopardy with all these problems. And I put in a 16-gauge IV cannula in the right jugular with the tunnel catheter in situ, and contrast was injected, and which clearly showed the presence of oh, the video is not working. Yeah, the negative shadow in the SVC showed the presence of the thrombus. And what do you do for this catheter-related SVC thrombus and atrial thrombus? SVC thrombus, at least, it could only cause this SVC syndrome, but atrial thrombus can lead to so many mechanical problems and embolic problems. So we had to act urgently, and the management options were catheter-directed thrombolytic therapy, and other theoretical possibilities were ultrasound-assisted thrombolysis, which is not available to us, and catheter-directed suction thrombectomy, which is again not available, and if everything fails, surgical thrombectomy. So we went ahead with thrombolytic agents, and we straight away used tissue plasminogen activator, TPA, and there are 3 available to us, FDA approved 3 drugs. I chose Elaxin, and but usage of this thrombolytic agent, the time matters. Most effective and used within 5 days after the onset of symptoms. Unfortunately, these patients, they develop this insidiously, and we don't get to them on the first 5 days. And the difference between these thrombolytic agents, I think we should get familiarized with this, because cardiologists are using this more. And for this patient, I gave a bolus dose of 30 milligram, and it promptly cleared most of the thrombus. Again, the video is not working, so fine. And this was his picture. The thrombolysis had a very good effect, and he was very happy. And the thrombus also, the size was 4.5 square centimeter area, which didn't call for any aggressive management. And it was a mural thrombus, it was not attached to the catheter. And the diameter of the thrombus matters for the treatment of atrial thrombus. But here we had other issues to be clarified, whether to keep the catheter in or how long to wait for thrombus to lyse, and when to resort to surgical management, and if there is stenosis later, whether to take him for angioplasty or stenting. And this is the management protocol going by the size of the thrombus. If it is less than 2 centimeter, you simply remove the catheter and forget the thing, the atrial thrombus will go away. In between 2 and 6 centimeter, if he has no surgical risk, then he can be submitted for surgical thrombectomy. But with high risk, you can continue a thrombolytic attempt and continue with anticoagulants. And most of them get to reduce the size. If it is more than 6 centimeters, then we may have to aggressively manage. And there is a new device called AngioVac, which can suck the thrombus by vacuum. And see, we should know as nephrologists why we have this risk of thrombosis. It is the duration of the catheter, and it is higher in the elderly, higher in systemically ill patients, and all these comorbidities. But this boy was young, he was not a diabetic, he had no comorbidities. And as far as I could investigate, he had no hypercoagulable state either. And the catheter age was less than 3 months. And the material of the catheter also matters. They say polyethylene catheters, which is the one we use these days, have higher chance of thrombus when compared to silicone rubber ones, which we don't use now. And but this peculiarly this boy didn't have much of this. And site of insertion, risk was approximately 4-fold higher if the insertion site was in the internal jugular rather than the subclavian vein. So in this aspect, internal jugular is worse than subclavian. And the position of the tip of the catheter. Tip in the brachiocephalic vein is more prone to produce brachiocephalic thrombus. And if the tip is in, we are in a dilemma now, which is the ideal position. But our recommendation is to put it in the atrium to get more flow. So we'll have to strike a balance between risk of thrombus and the amount of flow you will get. And other proposed causes are there, injury to vein. Actually, while putting in a tunnel catheter, we try to take the guide wire into the IVC. That time, sometimes we meddle around with the guide wire, which can damage the atrium and cause the more prone for thrombus. And this tip position I discussed just now. And presently, his thrombus has gone down drastically, and I think it will disappear. But unfortunately, what happened, I had to make alternate access. So I put in see, he was on a severe anticoagulant, and to put in another access is a problem. So I resorted to femoral tunnel catheter, and he bled profusely. Then I had difficulty controlling the bleeding. Then we had to stop the anticoagulants, and his thrombus got aggravated, I think. And now again he has the SVC thrombus and SVC syndrome. So the problem is not over here. So managing this case, it is not so much so about diagnosis, but we have problems like creating fresh access with full anticoagulation, where to create, and the cost involved in all this, and fear of pulmonary embolism from the atrial thrombus. I think I will stop here, and thank you.
Thank you, doctor. I think you were very lucky that this the medical therapy worked, because I think this was an ideal case for surgical intervention. We had a similar situation like this, where surgical removal of the clot make a big difference. Yeah. I think you all, Dr. Vijay, please.
I must say that Bala is a quiet guy, and he is one of the most experienced interventional nephrologists. He has been making fistula for long periods of time. He is very quiet, sort of humble.
Thank you.
Well, I hope you all enjoyed this session. You see, as per Hutchinson, the eye does not see what the mind doesn't know. So here, I think we have been educated enough, and will make better diagnosis and better management in the future. Thank you, everybody.
Thank you very much, Chairperson sirs. I think we had very interesting 7 cases, right from COVID-related complication, catheter thrombosis, and mucormycosis. I mean, a lot of issues. Possibly everybody is a little tired, it appears. But we have got 2 professors, Professor Sri Bhushan Raju and Professor Pinaki. They got delayed because of traffic and other things. I will only request them, as professors, they can finish their talk in 5 minutes each. One is talking on a very important issue, that what is the present status of denervation therapy in managing hypertension, and what is the future. And Dr. Pinaki is mentioning what is the present status of ANCA-related vasculitis management. I'll appreciate that with their presentation, professorial, they will attract the attention of everyone and try to finish in 5-6 minutes.
Yes, good evening, everyone. And probably I need to rush through the slides, and this again and again I got an opportunity to speak for only 5 minutes. Previously also I had several opportunities. Topic given to me is renal denervation. You know that activity of sympathetic nervous system in the initiation and the maintenance of hypertension is very well known. So resistant hypertension is seen in more than 13% of the patients, where we require to give not only the drug therapy, we need to have an intervention related to that. So when the drug therapy fails, when the non-compliance, or otherwise also we need to have some other modality called renal denervation, where the afferent and efferent arterioles which are located in the renal arteries will be denervated because with an invasive catheterization based procedure, and radiofrequency ablation will be done to them so that hypertension will come down. In fact, it is the first one treated for the hypertension before the chemotherapy started, drug therapy given to them. So radiofrequency ablation is the most common method. It can be given not only in that ultrasound based, or the chemical renal denervation also can be given. In 1930s itself, it was started much before the drug therapy for hypertension. Then after, it was the thoracolumbar sympathectomy. Then afterwards, this is the latest therapy which is being given, where the catheter will be introduced into the renal artery, and the circumferential renal ablation, renal nerve ablation will be done in the renal artery so that hypertension can come down. And these are the set of trials which have been done, which were already done and undergoing now. And the Simplicity Hypertension 1, 2, 3 are the most important trials. Simplicity Hypertension 1 is actually an open label trial of 153 patients, where the proof of concept was actually done, and there is overall response rate of 80% at the end of 1 year. But it was a small study. Then randomized control trial of Simplicity Hypertension 2 trial with 106 patients were done that showed a significant drop in hypertension. Of course, it was more in the office hypertension rather than hospital-based hypertension. Then the trial Simplicity Hypertension 3 trial took place in 503. It is actually a sham-based control trial, and this showed significant drop, of course, but it did not really make much difference in that, providing it led to the suspicion that the radiofrequency ablation might not really improve the hypertension in those patients who are resistant. So many other trials like DINER-HTN trial with 106 patients also demonstrated very well that ambulatory blood pressure monitoring was done in these patients, and then radiofrequency ablation was given. Compared to the standard care antihypertensive therapy, at 6 months, there is a significant drop in both the systolic as well as the diastolic blood pressure. We have another few trials like Spiral HTN off med and on med. This is basically to say that without a single medication, without any antihypertensive therapy, if the patient undergoes, this is off med. Along with antihypertensive therapy, it is on med. This trial also showed very well, significantly reduced the blood pressure compared to the sham control in the absence of antihypertensive medication. And the Spiral HTN on med also showed a similar significant reduction in them. And these are the trials. And ultrasound-based renal denervation ultimately proven to be of efficacy. And this is the Radiance HTN solo trial, which showed importance. So who will get benefited out of radiofrequency ablation is the one, those patients with the isolated systolic hypertension, those with the high central pulse pressure, those with increased aortic pulse pressure will not get benefited, and it has got little effect on those patients with the low sympathetic activity, and that is hypertension induced by renal artery stenosis, and it will be also less effective in those patients with the volume dependent hypertension. Whereas the methodology, the types of catheters are also equally important in producing radiofrequency ablation. And it is very well known that some of the experimental animals showed that renal artery regrows its own sympathetic nervous system again, both afferent and efferent arterioles within 6 to 12 months. So it is still suspicion that whether the afferent arteriole and efferent arteriole renal frequency ablation can really make a difference in controlling the blood pressure or not. And there are definitely some hemodynamic changes would take place after the radiofrequency ablation, and both aortic pulse pressure, carotid femoral pulse wave velocity, aortic augmentation index, and peripheral vascular resistance, everything would come down after denervation. And GFR would not get affected. That is one of the very important things, as well as the renal blood flow would not get affected after that. To conclude, radiofrequency ablation or renal denervation is one of the most effective measures in refractory hypertension, but there are several studies have been taken place already, and we are going to see so many other studies also in the pipeline, and it will not have an impact on the graft kidney function. At the same time, it will definitely decrease the hypertension in those patients who are resistant. However, long-term studies are really required, and the sustainability of the hypertension at the end of 3 to 5 years also we should be able to see. And it has got its own complication. Patient requires a severe anesthesia, and pain will be there, and you should be able to give anesthesia and sedation, and that's the only thing. Otherwise, it's a very simple procedure that can be done easily through a very good guided procedure. And I thank you very much for the kind attention. Thank you.
Any complication of any stenosis, because you don't know that it will be damage.
Good night. This is the last topic, and I will try to finish by 5 minutes. The thing is that ANCA-related vasculitis, the recent update is in spite of the lot of therapy, lot of procedures and all these things, but still it is a mortality is high. It is about 80%. And the role of ANCA pathogenesis, the direct role, the new thing is happening. What is the actually the basic culprit? Who is the culprit? Whether that is a T cell, B cell, or the alternative pathway, that is the new way of rethinking of this process. In the pathophysiology, that is, we know, that is mostly that is T lymphocyte, T effector cell, B lymphocyte, all are there. But there are new way of pathogenesis now come out. That is B cell preponderance and the independent of the T cell B cell activation is the much more important. And another important thing that is coming out, that is the C3-5A, anti-C3-5A and drug, and that is the advocate trial that address this C5A receptor antagonists have a definite role. And in a study, that is advocate trial, they have shown characteristically that is the patient having the avocapan, though it is not present in our country, but still the patient with the avocapan have the much more remission rate, much more outcome, better outcome, definitely have an advantage over the non-avocapan group. Second important thing is that the role of B cells is the newly thought of, and this is a T independent B cell proliferation and activation is a new concern. So the role of rituximab now came out in a different way. So rituximab tried in the induction phase, rituximab tried in the maintenance phase, rituximab with sacrificement is tried, rituximab sacrificement with the plex has been tried in the different trial. The induction phase, the RAVE and rituximab trial compared to rituximab, and with the cyclophosphamide, there is no inferior. In the maintenance phase, this mainstream trial type 1, 2, that is also having a better, and they have shown the duration of this group of patients who having the monitored in the CD20. And this main recent 3 trial that actually addresses how long this rituximab should be given. And combining the rituximab to have some small trial have better benefit, but no consensus. But the new thing is that the role of BAF and April, that is a B cell activating factor, and that is a protein, there is a ligand, interferon ligand, activating ligand. What is the basic things is that they prime the B cell, they prolong the B cell, and they increase the autoantibody. And so the thing is that is the when the buff, when the by cleavage is actually put on this base cells, they actually 3-way T cell, B cell, and other the short-lived plasmablastocytes. It increases the ANCA, and that increases the disease pathogenesis. So they have tried the anti-BAF therapy in the ANCA vasculitis. The previous trial, they have it is already ongoing trial. They have showed there is a very benefit, but it is not not actually taken as a consistency in that as a part of treatment. And regarding the thing is role of plasma exchange in the MAPEX trial, that is you have seen, there is a MAPEX trial is very, very beneficial in this severe group of ANCA vasculitis with the alveolar hemorrhage. But after the Pixifas trial that actually come in, it is a very well designed trial. They have shown no such good result along with it. But the false is there. False is there. There is the limitation is a baseline renal Pixifas is only 30%. In 10% patient with the plex, some didn't complete the prescribed plex, and primary outcome analyzed after one combination of the rituximab, cyclo, and the plex. And ANCA, another thing that is actually discussed in the now that is ANCA positive disease versus negative disease. They have shown there is an ANCA negative possible glomerular are much more dangerous than ANCA positive. And because they have shown histologically that there was more concerned, prominent B cell involvement is there that actually enhance the use of rituximab, and the role of plasma exchange, still it is a controversial. Thank you. Yeah. In the as the we have seen, that is the now much more. Yeah, it is a non-inferior study can be given. Status of recombinant also shows that is a really good drug, but the thing is that is a costly and it is not available. So it is still not useful in all the country. Yeah, ANCA negative is a much more dangerous than the ANCA positive because it appears much early age group. It is much lead to ESRD much earlier and outcome is very poor. So you have to much address much more than in this ANCA negative possible glomerulonephritis.
Thank you very much, Professor Pinaki. I think though the time has been different, but if you really think back, all the speakers have done wonderful job. You started from beginning, whether it was Professor Ashwin Gupta, what he spoke about the COVID-related glomerular disease, whether it was inhibitor should be given, whether it is denervation therapy, this ANCA, everything gave the right message. There's a lot of learning for every one of us. That is the latest what is developing. We are going back with some knowledge that what is going to come in the near future, what trials we are expecting in the near future. I once again thank all the speakers and the chairpersons for the wonderful presentations and the time they gave for the conference. Now I think I hand over to the organizers, Mr. Raja. And we thank again the Microlab for all the arrangements and wonderful the conference, whether it's Dr. Raja or Deepak, everybody, all the team has done very good job. 3 cheers for them.
Sir, I request 5-10 minutes of your valuable time. I want to thank all our speakers and delegates who has attended this meeting. And I request Mr. N.K. Raja to come out on the stage and felicitate our course directors. Before that, I would also request Dr. Ashwin Gupta, Dr. Babu Francis, Dr. Bhushan Raju, Dr. C. Arvind, and Dr. Pinaki Mukherjee and J. Balasubramaniam sir to come out on the stage.
Thank you, sir. Please come over, sir. I think it is our duty to certainly thank all these 2 course directors, Dr. P.P. Verma, as well as Dr. Vijay Kher, who have been instrumental in taking a good journey towards this particular CME, the Regain program. And as I told you in my earlier talk, we have completed 50 such programs, and this will be our 51st program. So I think a program of this such stature cannot be possible without the valuable time that has been spent by both Dr. Vijay Kher and Dr. P.P. Verma. So it's our duty to felicitate both of you, sir. Please come over onto the stage.
Yes. Next. This side is भाई साहब हेल्प करता हूँ कॉर्नर में रखता हूँ बट साउंड चाहिए I request all doctors to come on the stage. We'll have one small group photo. And we are having all felicitation for all other speakers and delegates also. Please. Sir, Verma sir and K sir, please hold on. Just sir. Cordless. Next, I request Dr. Ashwin Goyal and LK Tripathi sir to come on the stage for conducting wonderful chairmans. As a chairperson, they have done wonderful work. We want to felicitate Dr. LK Tripathi sir and Ashwin Goyal. Sir Tripathi sir and Ashwin Goyal sir. I request Vijay Kher sir and Verma sir to come on the stage to hand over the trophy of Ashwin Goyal sir and LK Tripathi sir. Sir, Abhi, yeah.
Can you remove this tag?
Next all. The stage, we request all the speakers of best of EDTA topics, that is Dr. Ashwin Gupta sir, Dilip Balla sir, Arvind C sir, Sri Bhushan sir, and Dr. Pinaki Mukherjee sir, please come to the stage.
Ensure all the doctors, MDs are also there. JB sir next. No, it will be in last. One second.
So next, I request Dr. Giri sir, Dr. Babu Francis sir to come over for handing over the trophies of anemia management speakers and panel discussion participants. Babu Francis sir, Dr. Giri sir, please. I request Dr. Sanjeev Gulati sir, Solanki sir, Dr. Ramesh Jain, Dr. Deepak Kalra, Dr. Sandeep Gupta, Dr. Manjunath S, Sandeep Chauhan to come on the stage. Sanjeev Gulati first. Dr. Sanjeev Gulati. Ramesh. Deepak Kalra. Manjunath. Manjunath. No, he's in delicate. Small one. For award the formal Dr. Niran, Dr. Giri. Please go. Sir, next I request the speakers of interesting and challenging case studies, Dr. Geet Bajpai, Tarun Kumar Saha, Ratan Jha, Dr. Kandaswamy, Dr. Sanjay S, Dr. J. Balasubramanian. I request Vijay sir and Verma sir to come over the stage to hand over the trophies. Dr. Geet Bajpai sir, Tarun Kumar Saha sir, Ratan Jha, Dr. Kandaswamy, Dr. Sanjay S, Dr. JB sir. Sir, Dr. Ratan. Next, I welcome Dr. Sri Bhushan sir and Arvind sir to come out on the stage to hand over all delegate trophies. Dr. Sri Bhushan sir and Arvind C sir. So our esteemed delegates, Girish NS, Dr. Mallikarjun, Dr. Babu Francis, Dr. Vivek Rohila, Dr. Amit Jaiswal, Dr. Vineet Kumar, all of our delegates I'm inviting, Dr. Shanmugaraj, Dr. Deepak Kumar to come out on the stage. And Dr. Giri Padmanabhan sir, Sham Shankar Verma, Joseph Vinnu, Dr. M. Venkata Viswanath from Vijayawada. I request Arvind sir and Bhushan sir to hand over the trophies to our delegates. Dr. Mallikarjun sir, is there? Dr. Sabirwal sir? Dr. Sham Shankar Verma sir? Dr. Vineet Kumar sir? Sir, Dr. Venkata Vishwanath sir? Sir. Dr. Joseph Vinnu sir? Dr. Venkat Vishwanath sir, please come out the stage. No. Any other? All come. I request our division manager.
किससे? कौन कह रहे? Dr. Sanjeev Gulati, can I request him to come on stage? Dr. Bala. Dr. Bala. Dr. Dilip Bhalla, please. Dr. Ashwini Gupta, please. Ashwini Gupta and Dr. Ashwini Goel, please. I think this is a big event for them, yes, for
launching
microlab, because they are launching ferrisome IV preparation.
Yes, it's an iron isomaltose preparation, sir. I think anemia management was discussed, and this is a new molecule which you want.
For any organization, this is a huge thing, and all the stalwarts here, basically it is to launch the product. सर इधर पकड़ो ना आप, तो आप पकड़ो।
By photographer.
All the very best.
Thank you very much, sir.
Available